Okay. Good morning, friends. Respected President, IMA Mumbai branch, Dr. Sujatunnisa Attar, all the delegates, I welcome you all on behalf of IMA Mumbai branch. As you all know, we are celebrating World Heart Day today. We are fortunate to have MMC President Dr. Shivkumar Utture, who was our past president, Dr. Hoju Kapadia, who is a past president of IMA Maharashtra State and our branch, Dr. Anil Patnekar, who is a immediate past president, vice president of IMA headquarters. I welcome them all. I also welcome today's speakers who are from all over Maharashtra. Dr. Niteen Deshpande, Dr. Ajit Bhagwat from Aurangabad, Dr. Niteen Deshpande is from Nagpur, Dr. Deodatta Chafekar from Nasik, and Dr. M.S. Hiremath from Pune. Friends, last few years, Dr. V.T. Shah has successfully arranged this program and we got very good response every time. This time we have speakers from all over Maharashtra. That response will be more than what we used to get. Because of this COVID, we cannot have this live program since last few months. But this novel way on web-based CMEs, it is good to have more than what we get on a live program, so many delegates. I again welcome all of you. Friends, because of COVID, you all know, last few months, everybody was focused on treatment of COVID, right from authorities to the doctors. But let me tell you, not many of patients other than COVID suffered a lot. Even last week, I had one patient of acute myocardial infarction who was refused admission in 2 hospitals in Mumbai only because he was not having a COVID report. So today, I think all these eminent speakers will guide us not only on cardiology, but also give us some tips on how to face such situations. And I'm sure this program will be appreciated by all. You must be remembering that on last 13th of September, we had a very successful AMS conference of Maharashtra State, and we hosted that with an overwhelming response, not only from Mumbai, Maharashtra, India, but from all over the world. And I am sure today's CME will be a great success. Thank you all. Friends, we will be having 2 more CMEs next October, coming October 11th and 18th of October. Now, without wasting much time, I will request our President, Dr. Sujatunnisa Attar, to give her presidential address.
On occasion of World Heart Day, we are having a CME to bring awareness among the doctor community so that in turn they can educate their patient regarding the problems that we are facing because of the heart problem. This year, we should scale up our prevention of heart attack and stroke as cardiovascular disease take the lives of around 17.9 million people every year. World Heart Day is a perfect platform for the cardiovascular community to see that this prevention is done among the general population. We don't know what course the pandemic will take in the future, but we know that taking care of our hearts right now is more important than ever before because cardiovascular disease is the #1 cause of death on the planet. World Heart Day is a global campaign during which individuals, families, communities, and government around the world participate in activities to take charge of their heart health and that of others. Now, without wasting much time, I will hand over the mic to the chairman, Dr. V.T. Shah, senior cardiologist, who is the chairman of the subcommittee of IMA Mumbai branch. And from here onwards, he will be talking about all the consultants. He is a senior cardiologist who is practicing in Mumbai for the last 30 years and been associated with Mumbai branch as the chairman, conducts a cardiovascular program every year. Over to Dr. V.T. Shah.
Yeah, good morning, everybody. Thanks, President Dr. Sujatunnisa and Secretary Dr. Bandarkar. And thanks to IMA for giving me this opportunity again to host a World Heart Day program. I think this is almost the 15th year of our hosting this World Heart Day program on behalf of Mumbai IMA. And though the World Heart Day is on 29th Tuesday, we celebrate it on a Sunday so that more and more people can attend this webinar. Now, before I go to the actual program, let me first take this opportunity, since this is the first official webinar I am doing on behalf of IMA Mumbai branch. So let me first congratulate all our doctor fraternity who have been working as warriors during this COVID pandemic. Not only those who are attending, but those who are not attending also during this COVID pandemic. And especially on behalf of IMA Mumbai branch, I would take the names of two exemplary distinguished doctors who have contributed a lot, sacrificing and taking risk of their own life to go in the field and work as warrior with door-to-door campaigning and door-to-door detection of COVID-19. So these are Dr. Anil Pashnekar, as Dr. Bandarkar said, our past president of Mumbai IMA, vice president of the national IMA, and has held so many posts, and a very active member also along with Mahim Dharavi Association. They have gone along with Dr. Uttare and their team to go to Dharavi and control the COVID pandemic, which has become now world recognized, that in a slum of such a thickly populated, the Dharavi Association and IMA together have contributed a lot. To talk about Dr. Uttare, we all know that he is president of our Maharashtra Medical Council and now a member of the National Medical Commission, which has been recently formed. And besides this, he has been a COVID warrior and has won many awards from corporators, from the Member of Parliament, from BMC, and from our Health Minister, Mr. Tope. So besides that, he has won awards from the media also. He has given so many interviews and educated the public about how to tackle this COVID on TV and news and all that. Very active role, and therefore I think that these people are eligible for Padma Shri awards, and I think that the IMA Mumbai branch should take initiative to recommend their names to the government for this award. So with that, I congratulate IMA Mumbai branch and the Mahim Dharavi Association to do this exemplary work. So coming now back to our topic, as we said today, like the 15th year to celebrate World Heart Day on behalf of IMA Mumbai branch. So we, in this COVID pandemic, took this opportunity to take the best of our the cardiologist and the specialty fraternity to bring this webinar. So I thought this is a good opportunity to involve all the experts from around Maharashtra. Although they are working in different parts of Maharashtra, let me tell you that all four of them are from Mumbai University. So with that, I would start my lecture first. Can you go to the slides? Okay. Can we go on to my slide? Okay. So if you stop sharing, then yeah. So if you stop sharing, then I can share my slides of today's topic. Samir?
Yes, sir. I click on that plus sign.
Samir, can you stop sharing?
Yes, sir.
Yeah, stop sharing so that, yeah. Now, I would like to go to my share screen. I can't
Yes.
see yet.
Click on the plus sign, sir, left hand side,
Yeah. Got it.
and there is a share screen option.
Yes. And then, okay.
Sir, below the
So-
entire screen, you need to select the small box and then click on share button.
Yes, 1 second. Let me see now. So,
Yeah, your screen is shared.
okay, let me see. Sorry. So now, can you see my screen?
Not yet, sir. It is uploading.
Is it still uploading?
Yes, sir. Have you clicked on the share button, sir?
Yeah, I have clicked on share button. It's on the slide mode.
Yeah.
Still not?
Not yet, sir. Not yet.
Okay, so I try and stop sharing and go again?
Yeah, sir. Please try it once again.
Stop sharing. And go again. Left click. Share screen. Loading. And click. Share. Now. So tell me.
Yeah.
Is it loading?
Sorry. Yes, sir. Yes, sir. We can see you. Yes, slides.
Yeah,
are-
we can, sir. Just
Yeah. Okay. So, friends, today I'm going to brief you about this topic. Whatever topics I have selected are relatively fresh so that they are not overlapping with many of the webinars which you are attending. And I thought that we would take up some novel topics. Now, this is one. Is your pulse rate a risk factor? Is your resting heart rate a risk factor? So,
requesting you kindly do the full screen.
yeah, I'm on full screen on my side.
Okay. Yeah. We can see that now. Thank you, sir.
Yeah.
Yes, sir. Done.
So what I'm going to do is take you through this journey and impress upon you the importance of the resting heart rate. Actually, I wanted to label this topic as a resting heart rate. So now, if you go back to our history, what about animals? If you see, the mouse has a resting heart rate of 500 and the lifespan is 2 years. And the elephant has a resting heart rate of 28 and the lifespan is 60 to 70 years. So is heart rate important? Yes. If you can make out, it has directly proportional to the number of life years you survive. So heart rate is important because you want cardiac output. Output is required to supply the blood circulation and oxygen throughout the body. So for cardiac output, you require a certain rate and a certain stroke volume. And based upon the size and based upon the function, this heart rate is decided. So if you see here in this slide about all this, so the mouse starts with 500, and if you come down, the monkeys are around 200 to 300. Their lifespan is 10 to 15 years, and you come down to whales and you come down to man over here, where the lifespan is 80 to 100 with around meant for 60 to 70 heart rate. So this is it. So let us go now. First, what are the factors which can? Now, typically, if you were to define sinus tachycardia, it is more than 100. But we all know that more than 100, of course, and it has to be sinus, a sinus rhythm. regular rhythm. But if there are supraventricular tachycardias, atrial fibrillation, ventricular tachycardias, all sorts of arrhythmias, we know they have event rates higher than the normal. But within the normal, which is 60 to 100, as we call a resting heart rate, is that important that if you have 60, it is better or worse, and if you have 100, it is better or worse? So we all know that the pulse is generated from the sinus node, which is the yellow here, and that gives us this ECG complex. And this sinus node is regulated by all the stimulus, especially the vagal stimuli and the sympathetic stimuli, which we know is controlled by the brain, especially hypothalamus, the brainstem, and the cortex, and all that. So it is all these controls, a balance between vagal and sympathetic, which decides the heart rate. And in turn, this vagal and sympathetic, they control the peripheral vessels, they control the organs, and so on. So heart rate is not basically only from the sinus node, but basically controlled from the brain. So what does all our epidemiological studies tell us, or population control studies tell us? We all know that all the elite athletes have a basic heart rate of 40 to 50, and they live longer. So the lower the heart rate amongst the athletes, the longer is the lifespan. What about the normal population? Now, this is a Scandinavian study known as the National Finris study. See the women. Now, these are normal people. These are not diseased patients. So they found out that in a 15-year study, they found out that if you take in women a heart rate more than 64, then what you see here is after 80, there is a jump in the event rate. When we say event rate, this is cardiovascular mortality or coronary heart disease mortality in this particular study. And as far as men is considered, right from more than 60, the mortality rates increase and they jump when they go above 80. What does this mean? This means that men should have a heart rate of nearly 60 to 70, and women should have a heart rate of 70 to 80. Then if not, then for every 10 beats or every heart rate increase, you will get more mortality amongst this. So this was a Scandinavian study. Let us go to the European study. Now in European study also, if you see the last sentence, increased heart rate has been associated with increased cardiovascular risk in both men and women, and has also been associated with increased risk of developing heart failure. So very important, cardiovascular risk and heart failure. What about the Americans? This is about the Framingham study. If you see here, if you go less than 65, you can see here coronary heart disease rate, then the cardiovascular rate and all-cause rate. So it is not only cardiac deaths, but all-cause deaths also increase with increasing heart rate. You see here, it goes up and up as you go up. So if you see here, more than 65, it jumps, and then more than 75, it jumps, and more than 85, it jumps. So this is the American study, and then they went out to give a long follow-up study with different characteristics of age less than 65, more than 65, male, female, diabetic, non-diabetic. They formed uniform that if you have a higher resting heart rate, it is associated with both cardiovascular and non-cardiovascular mortality. Which means what? That even within 60 to 100 range, which is so-called normal, if you have a higher resting heart rate, you have more chance of cardiovascular mortality. Now, what about certain subsets? This was what I spoke about, is about the normal population. But what about certain subsets? Now, let us first go to hypertension. This was a study which showed that during control of hypertension, whether it is by any of the group of drugs, in this study it was ARB versus beta blocker, they found that if the heart rate is less than 84, you see this blue line, the event rate is less, and if it is more than 84, the event rate is high. So when you treat hypertension, you ought to have a resting heart rate of at least less than 70, so that if you have resting heart rate more than 85, with good control of blood pressure, even then the mortality is more, or infarctions are more, heart failures are more, or mortality. So in short, we call this MACE, MACE, major adverse cardiac events. So we call this MACE or event rates are more. So when you treat hypertension, and in today's subsequent lectures, you will hear the role of beta blockers in hypertension, and then in heart failure also, diastolic heart failure. So now this is another study. So besides hypertension, the next study is about heart failure. The more the resting heart rate, the heart failure incidence is more, despite having a good control of blood pressure. So with every 10 beats increase, 11% increase in incidence of heart failure, almost 1% for every heartbeat more. So this is one study which showed incidences of heart failure more. And in the same live study, again, if you see here that you get better benefits if the heart rate is less than 84, less incidence of heart failure than when the heart rate is more than 84. Now, what about those patients who have coronary artery disease? Whether you require a lower heart rate in that or not. So here, if you see here that once you cross the 70 mark, the graph goes up, which means what? That you should have basically a 60 to 70 heart rate, which will give you an average risk rate. Now, this is also another study. This is data from On Target Transcend. You all use telmisartan in your practice. This is a trial on telmisartan, where we saw again that if the heart rate, despite getting good control by telmisartan, is not controlled, it goes about 70, then the event rate goes up, more deaths, more heart failure, and more all-cause deaths. So all these molecules, BARB, beta blockers, and all this have shown. What about myocardial infarctions? We have all seen now that those myocardial infarctions who come with a heart rate more than 60 to 80, they have a high mortality. They come with 100, 140, and as you see, then they are more in cardiogenic shock, and therefore this patient, this is from the GC study, that you have more heart rate at. Now what about heart rate at discharge? I showed you a slide of admission, but at discharge also, if you don't control the heart rate, then you have higher mortality, and the survivors would be less. So anything above 70 or 80 would be this. So why is it important? What does heart rate has to do? If you see this, an increase in heart rate means a decrease in diastolic duration. We all know that heart rate, the heart has got a systole, contraction phase, a relaxation phase. If the heart rate is fast, there is not enough time to relax for the heart and to become strong again for the next contraction. If the diastolic duration is small, then the perfusion of the coronary arteries is less, the oxygen supply is less, and then there is pump failure, as you will see in subsequent Dr. Ajit Bhagwat's lecture about diastolic heart failure. Similarly, once the heart rate is increased, you get more cardiac work to do, and then therefore there is increased oxygen demand. So there is more demand and less supply, and therefore it is damaging to the heart. Now how does it play around? Now if you see here, besides all these cardiac problems, we have seen that a higher resting heart rate predisposes to obesity and diabetes in the general population. If you see these yellow things, there is more. Therefore, I think it is very important in a population that at a very young age, you try and avoid a resting heart rate by exercise and yoga without drugs, and see that the incidence of diabetes and obesity is less. What about the resting heart rate above 75 to 80 was associated with worse CV outcomes in diabetic population. So this was another study. Now what about lipid profile? We have seen that if you have an elevated resting heart rate, then you have a more atherogenic lipoprotein profile, which means what? In obesity, you get high triglycerides, you get low HDL, you get high total cholesterol, and a very high low HDL. So all these things are related to heart rate also. So there is an increasing risk factor when you have a resting heart rate about this. Now, this is about microalbuminuria. I am sure Dr. Chafekar will also address microalbuminuria. And in hypertensive patients, we have seen that if the heart rate is more and the patient is hypertensive, the microalbuminuria incidence is more. So this also is this. Now all this interplay, as I told you, is all based upon the sympathetic nervous system, and the sympathetic nervous system, increased heart rate gives rise to increased sympathetic nervous stimulus gives rise to increased heart rate, which gives rise to obesity, diabetes, along with smoking and dyslipidemia, metabolic syndrome, and don't forget sleep apnea syndrome. And it gives more event rate in hypertensive, ischemic heart failure, kidney disease, and cerebrovascular diseases. So all this is interlinked, and the basic mechanism could be arterial remodeling, cardiac hypertrophy, endothelial dysfunction, more atherosclerosis, more arrhythmias, and more plaque ruptures, giving rise to. So this is just a schematic thing, as whatever I discussed just now in the previous slide, that these are the mechanisms by which. Now the next question you will ask me is there a benefit if you reduce the heart rate, whether it is by exercise, yoga, or stress relaxation, or whether it is by drugs? So we have seen these benefits, that you have better endothelial function, you have better walls, vascular wall stress, you have less of infarctions and less of heart failures. So now if you get a patient in your practice with a high resting heart rate, we all know many patients come, साहेब याची छाती नेहमी धड़धड़ करते, इसका तेज चलता है नस, and so on. How will you evaluate those patients? So you see at the symptom status, you see the clinical examination, see first of all whether the pulse rate is regular or not. Only if it is regular, then this question comes. If it is irregular, then it goes into arrhythmia section. So see whether it is irregular, and if you have any doubts, take the help of pulse oximeter, and on the oximeter, take a oximeter, the pulse oximeter, which has a waveform, which doesn't give you just simple numbers. You should buy oximeters which have a waveform below, which will tell you that whether they are regular or irregular, whether there is a high peak, a low peak, and so on. So that will decide whether your blood pressure is regular or not, or the pulse is regular. And then you can send the patient for ECG, 2D echo, TMT, Holter, and all that to find out whether the heart rate which you see in your clinic is faster, and at sleep, during sleep, whether it is normal or not. So then, of course, exercise and relaxation therapies are the mainstay. And then if required, we can use the help of beta blockers. Rule out exercise, fever, anxiety, anemia, dehydration, thyroid, septicemia, embolism, diabetic neuropathy. And in today's COVID era, I would say that sometimes a faster heart rate could be one of the features of COVID-19 presentation. Just patient saying, not only I'm feeling breathless, but my resting heart rate is too fast, then it could be an involvement of myocardium, whether it is myocarditis or whether it is plain and simple pneumonias, and so on. You should see the history of drugs like atropine compounds and nitrates and beta-2 stimulants, especially in asthmatics and COPD, we give all these drugs, and of course some cardiac diseases. And lastly, if nothing goes, then maybe this patient has got a syndrome of inappropriate sinus tachycardia. Beta blockers are helpful, especially in those patients who have MI, who have heart failure, and in hypertension, atenolol is not beneficial, but maybe other drugs like bisoprolol. You will see here all this in the next lecture. I don't want to repeat that. What about calcium channel blockers like verapamil and diltiazem? They do reduce the heart rate. They are good when there is associated with hypertension, but not when they are associated with heart failure. There are newer calcium channel blockers like cilnidipine, benadipine, nephrodipine, ezilnidipine. They reduce the heart rate in hypertension, but they have no outcome data as on today. The third drug is ivabradine, which reduces the heart rate without affecting the blood pressure or without affecting the heart failure status, and they are very useful. They have been proved to be useful in LV dysfunction patients, in coronary artery disease patients, in heart failure patients, and they have been very useful without affecting the blood pressure at all, or causing any heart failure symptoms increase. So, in management of hypertension, especially now the ESC has given guidelines that you should use drugs and bring down the heart rate to less than 80. I would say you keep it between 60 and 70 if the patient have no symptoms with the heart rate of 60 and 70. So this is my concluding slide, and I would say lifestyle measures like exercise and yoga help to decrease heart rate. Please remember, inculcate these habits very early in the life so that you get a long-term 10-year, 15-year survival rate or an event rate. And in patients with hypertension, a high baseline heart rate is not good. You should range between 60 and 70, though guidelines they say less than 80, because they are associated with increased risk of cardiovascular events and development of heart failure. The current evidence, which is predominantly with atenolol, is not good. You should use the other beta blockers that we will hear subsequently. In chronic stable angina, again you should use see that the heart rate is controlled, especially 60 to 70. In heart failure, the same, and target the heart failure even in myocardial infarction patients. So a high resting heart rate is very important to be controlled, and not only when it is above 100. Don't treat them when it is above 100. Treat them when even if it is more than 70 in men and more than 80 in women. Thank you very much for your patient listening. Thank you. I will stop sharing now, and you can go on the video now. So what I will do is, can we see the other panelist? Yes, and the other speaker. So what we will do now is, if there is anything to be added about this topic by other panelists, then we can have their comments also. And if there is any questions on the chat box, you can put it on the chat box. Do we have a chat box, Amir? So, Ajit or Niteen, anybody to add?
Yeah.
Yes, sir.
VT, can I ask a question?
Yeah, please go ahead. That is what we want interaction here about.
Very, very interesting talk. And you correctly mentioned that in last few days, last 2 months, with this COVID, the number of patients with palpitation are coming to the OPD. Their only symptom is palpitation. And my question to you is, regardless of COVID status, if you see a otherwise healthy patient, say 50, 55-year-old, with a resting heart rate of 90, he has no other comorbidities, no other illness. What would be your advice?
Well, Ajit, a very practical question which you have asked and which we faced in day-to-day practice, that patients come and otherwise so-called normal, and whether they have. What I would say is, first of all, of course, with the algorithm which I showed you, to try and rule out any pathological causes, and if not, and if you still feel that this is just an isolated, I would still say that we might be having some form of subclinical infection. I don't know, that also could be possible, and maybe we should look for some, even if the RT-PCR is negative, we should look for some antigen or antibody. But if not, and if he's a normotensive patient, of course, anxiety or stress could be a factor which we could come into control. But after all this, if the patient has symptoms, I tell you, I put them on ivabradine, at least for the time being, for a couple of months till the symptoms subside, and he takes all the benefits of his exercise, yoga he gets, and then maybe try to taper it off. I don't know, what is your take on this?
No, I don't know.
Niteen, take on this. Do they treat with, because I find ivabradine otherwise a very safe drug, and at least it gets relieved of the patient's symptoms and his anxiety, because more anxiety, more tachycardia, more anxiety.
True. I mean, the point is, there is a lot of data coming which shows that increased heart rate is bad for health in any condition for that matter. So that's why this question always props up in my mind that asymptomatic and otherwise healthy resting heart rate of say 95, 100. I mean, is it disease or does it indicate anything as of today? That was the reason I asked you this question.
No,
I don't know.
I absolutely agree with you. There is no data to treat such patients like this. And maybe sometimes I find in our chats which we do on our WhatsApp that many of the EP specialists are not in favor of giving ivabradine even to this patient. And many say that you may give if the symptoms are not controlled by anything else. In olden days, if you remember, we used to give Ciplar 10 milligram for anxiety neurosis. In olden days, we used to give, and we all knew that beta blockers have some side effects, especially in young patients if you give, and they are long term not good. In these days, I think ivabradine is much more safer drug than Ciplar, that is propranolol. Of course, I took the commercial name, but it is propranolol 10 milligram. Niteen, you have to say something. I mean, you have excellent knowledge about this topic.
I don't know, Viti. Both you and Ajit made a very valid point. In fact, I have been checking my heart rate, and my heart rate always remains 84 to 88, and I'm perplexed. What to do? I think unless the patient is troubled with palpitations and there is nothing else, I probably would not try and reduce the heart rate with a pharmacological means. That does not mean that you don't try other methods. I think proper exercise training and breathing technologies can help a lot in controlling heart rate, and probably that would be, unless if the patient has too much of anxiety, where you correctly said that propranolol works very well. So I think that's about it as far as I am concerned.
Good. So, yes, Dr. Avhad, you have to say something. You're on mute, possibly.
There are few questions in the chat box.
Good. Can you please read them?
Yeah, there's one question from Dr. Nanak Khetani. Should CCBs be avoided in treatment of hypertension as they increase the heart rate?
Okay, so I did say that drugs like verapamil and diltiazem, they are the drugs which reduce heart rate amongst the CCBs. The newer drugs also do reduce the heart rate, and therefore instead of giving amlodipine or nifedipine, which increases the heart rate, we tend to give these molecules more. Of course, the problem with the newer molecules which I mentioned, they don't have long-term outcome data, but verapamil and diltiazem do have good outcome data when you treat them for hypertension. They have no data to treat them in normal tension patients. Okay, just as we mentioned just now to give propranolol for anxiety, we don't have data to give verapamil or diltiazem for anxiety or for sinus tachycardia.
Okay. So there's one more question from Dr. Manohar Kamath. PCOD with high insulin resistance, where obese patients are more prone to cardiac problem than thin patients. How it is?
Yeah, so basically, we did say about this obesity and metabolic syndrome problems, and in women associated with PCOD. You look, see, I think they do give this metformin drug for such cases, but if the heart rate is fast, and if the resting heart rate is too fast and is symptomatic, then I would say that yes, you treat these patients. But if not, then maybe I would not advise. If there are no symptoms, then you can take care of this with regular drugs, like treatment for PCOD. I don't know whether others have to add, because I have no such experience, much experience, I would say, except for few patients of PCOD infertility referred for some fitness.
Okay. Sir, there is one question regarding ivabradine. Dr. Vishnu Chandani has asked, can you combine beta blocker with ivabradine? And one more question is there, what are the benefits of ivabradine with beta blocker?
Okay, I see. I will reserve this answer for Niteen to answer this question. And I think Niteen, you want to take it now or in the next session?
Maybe now also we can talk about it.
Okay, fine. So I'll basically tell you the guidelines, especially in heart failure, they say, or for that matter in chronic stable angina, these are the two indications approved for ivabradine. If the heart rate, despite giving beta blocker, or if the patient doesn't tolerate beta blocker in high dosage, you can add this drug. So the guidelines do mention this, that they can be added. How, what dose and all that, I think Niteen will answer that question after his talk. Niteen, is that all right?
Okay.
Sir, one more question from my side is that, as Dr. Bhagwat has said, whenever any patient comes to us in the OPD, we check with oximeter and we invariably find that the heart rate is very high. It is almost 180, 118, 122. So how to, correlate that?
Yeah, so the first thing I would say is that as soon as the patient walks in your clinic, it is like blood pressure, it's going to be high. Give him a cooling time, 15 minutes, make him relaxed there, and then check the heart rate again, and see that the patient is not conscious to look at that pulse oximeter. Many a times they also keep watching that pulse oximeter and see a fast heart rate, and then again it increases further heart rate. Try to make him relax and involve him in some conversation. If you are busy, maybe you can ask your compounder or staff nurse, sister nurse to make him busy, and then quietly observe the heart rate, and then maybe find out. And then of course fever, this, that, everything you will try and rule out and see what it is like.
Okay. Thank you, sir.
Sometimes the heart rate goes up if your fees are too exorbitant.
Yeah. It happens with a cardiologist, not with
Good. So now let us go on. So can you show the slide of Dr. Niteen Deshpande, please? So now our next speaker is Dr. Niteen Deshpande, and he practices in Nagpur, and he is also a product of Mumbai University from Sion, and he is the director of Spandan Heart Cath Lab in Nagpur, and has many academic programs and publications to his credit. Very astute clinician and tremendous knowledge in all this kind of subjects, and they along with Dr. Madikar, they conduct this CAT conference every year in Mumbai and other parts of Maharashtra. So with this introduction, I will request Dr. Niteen Deshpande to please take over and give his talk on beta blockers. Dr. Niteen?
Yeah. Hello, am I audible?
Yes.
Okay.
Yeah, you are audible and we can see your slides also.
Right, thank you. At the outset, Dr. Shah, let me thank IMA Mumbai branch, President Dr. Attar, Secretary Dr. Bandarkar, and the galaxy of IMA dignitaries sitting there for having me involved in this program. I also want to take this opportunity to wish all of you and all of our viewers a very happy heart. Actually, we are really traveling in a very troubled time this time, and the COVID era has taken a great toll on everybody's mind as well as health. In fact, I myself suffered from COVID few days back. My parents are recovering from it. So it's a tough time, we all know, but the webinars are really keeping us going. So let's start with the presentation, and the topic given to me was actually controversies in beta blockers in hypertension. And to come to hypertension, I will just take you little bit, because we are also discussing about the World Heart Day. So some little statistics which will re-emphasize the importance of and the severity of hypertension that we are facing, and then why and how should we do about it. So if you look at the trend in hypertension, we have seen a huge increase in the cases of hypertension, especially these are the areas which are Asia and Southeast Asia. We have seen a massive jump in the cases of hypertension. We all know that India is a young country. We have plenty of young population, and the hypertension incidence is increasing tremendously in a very young population. So, Samir, yeah. So, once we know that, we also should know that hypertension is one of the very, very important contributors to cardiovascular mortality and morbidity. And hypertension actually accounts for about 50% deaths which happen because of stroke and heart disease. And there is a huge number that succumbs every year. And we also know that the cardiovascular risk doubles with each 20 millimeter increase in systolic blood pressure or 10 millimeter increase in diastolic blood pressure. And interestingly, this starts actually at a very low level. This is a blood pressure collaboration group which have analyzed the figure, and they have seen that this risk actually starts increasing when the blood pressure starts crossing 115/75. So it's a continuous graded relationship of blood pressure with increasing CVD risk. Samir? The down arrow is taking slides backwards actually. Okay. So now it's after we know that increase in blood pressure at 20/10 millimeter increases risk, it is also important to know that each 10 millimeter blood pressure reduction in systolic or each 5 millimeter blood pressure diastolic gives significant benefits. That means there is about 15% reduction in the cardiovascular deaths and about 20% reduction in the incidence of stroke. So treating hypertension and reducing systolic and diastolic blood pressure is very important. Now, if we look at the history of hypertension, the evaluation and the treatment, I'm sure we will have a number of senior members of IMA here in the group, and they would recollect the use of all these older drugs which have been there since 1960s and 70s. And we started with various alkaloids, and then the ganglion blocking agents, then diuretics, and then beta blockers came into picture. And then subsequently we had much better drugs in form of angiotensin converting enzymes, ARBs, and calcium channel blockers to treat hypertension. So if you look at the beta blockers, how do they act? Actually, the beta blocker usage started somewhere in 1970s, and it continued for almost 40 years for hypertension till recently we learned something new about beta blockers, which I'll share with you, which is not actually a very new, but it is about a decade old. But our habits are still the habits for last 20-30 years. So what beta blockers do is they are basically negative chronotropic and inotropic agents which reduce heart rate and the force of cardiac contraction. There is also action on the sympathetic nervous system, whereby you get antihypertensive effects of beta blockers. And these are the other classes of drugs which are available for us to treat hypertension today, and you see the mechanism there. And Dr. Shah in his lecture mentioned repeatedly that atenolol is a different beta blocker, and then there are a number of new beta blockers that we have in our armamentarium, like nebivolol, bisoprolol, metoprolol, and these are the drugs which are little different than the older drug, which is atenolol. So let's look at the guidelines. What do they say, and how should we manage our hypertension now? If you look at the recent ESC guideline, which was given in 2018, you see there the choice of drug starts with ACE/ARB and a calcium channel blocker with or without diuretic as a first line therapy. If you go back to the previous version of these guidelines, they had beta blockers also as first line therapy for hypertension. And now they have relegated beta blockers much lower as actually as step 4 drug. So why has this happened? ESC has downgraded beta blockers to step 4. This is another algorithm which is called as a NICE, National Institute for Clinical Excellence. This is a British committee, and which gives guidelines for management of hypertension. So if you go to the previous versions of NICE guideline, it used to call it as a ABCD algorithm. That means A is angiotensin receptor blocker or AC inhibitors, B was beta blockers, C was calcium channel blockers, and D was diuretics. And the 2019 NICE guideline now does not show beta blocker anywhere. What it says is, if you have diabetes, then the choices are different. If you have hypertension with diabetes, the choices are different, and the choices are depicted here. But what you see here is that it is again a AC, ARB, or a CCB as a first line, and then you try to combine them as you go on with inadequate control with single agents. And the ESC now recommends to start with a combination therapy or a single pill combination of 2 drugs to get a better effect. The beta blockers are down here, that alpha or beta blocker can be used if the blood pressure is not controlled with adequate use of all 3 agents, and the potassium limits use of a drug called spironolactone. Now, spironolactone is an extremely good 4th line antihypertensive agent, and that should be used ahead of beta blockers in most of the patients with uncomplicated hypertension. Mind you, we are talking about uncomplicated hypertension here. If the patient of hypertension has any other additional features like established coronary artery disease, heart failure, or arrhythmia, this discussion does not pertain to that kind of patient who has additional features. But for uncomplicated hypertension, beta blockers, according to the guidelines, should not be used as a first line drug. And why this happened? This happened because people started looking at the data of beta blockers that we have used over the years. And in 2005, we got this meta-analysis, which was given by Professor Lindholm from Scandinavia. And what he did was he collected all the beta blocker trials, all the previous trials, clubbed them together and started looking at the benefit of atenolol or propranolol, which were the main beta blockers used in the previous trial. And interestingly, what they found was, although beta blocker was a good drug if compared to placebo in treatment of hypertension, when it was compared to the other newer agents like AC inhibitors, ARBs, or calcium channel blockers, it actually gave little higher incidence of stroke in these patients. Although it was okay with incidence of myocardial infarction and deaths were similar. And therefore, this meta-analysis strongly recommended that beta blockers should not remain agent of first choice in treatment of uncomplicated hypertension. But if you look at the meta-analysis, I'm not sure how well you can see this slide because it's a busy slide. It depicts all the trials which were included in the meta-analysis. I want you to concentrate on the age of patients that were included in this meta-analysis. And you can see that most of the times these were patients who were 60 years and above. By definition, we say that adults above 18 years having elevated blood pressure are hypertensive. But when you look at the trials, you see a population which is very old population which is included in the trial, and therefore we base our conclusions from the trials. So all these trials are relating to mostly old patients, and all these trials are mostly relating to atenolol. So atenolol or propranolol, only one trial with metabolic But there, the number of participant was very small. So we must remember that all this critical data is coming from people who were 60 years or above, and atenolol was the major drug which was used in this trial. So what is the problem with atenolol? Problem with atenolol is that it has a half-life of 6 to 9 hours, and therefore when you use it in a once a day dosing format, towards the end of the dosing period, that means from hour 18 to hour 24, you actually start seeing wearing of the effect of atenolol. That is number one. Number two, atenolol also causes significant peripheral vasoconstriction. And in some of the data, especially the data from the Ascot trial, the CAFE trial, it is shown that although the systolic blood pressure is equally well controlled by atenolol to amlodipine, the central aortic pressure is high. And the third important thing is that there are metabolic side effects of atenolol, which leads to dysglycemia and dyslipidemia. So all these must be contributing to some problems with atenolol. However, as I mentioned, all these meta-analysis, it looked at the population which was older than 60 years, or it was a mixed presentation, and said that the stroke incidence is increased with beta blockers. Not everyone was convinced, and immediately after that initial meta-analysis, this meta-analysis was done by Dr. Khan, who looked at almost 150,000 patients enrolled in the same trials, and he tried to segregate them with people younger than 60 years, where beta blockers actually are beneficial, and people above 60 years, where the beta blockers are not that beneficial, or maybe they are causing little harm. And therefore, this meta-analysis concluded that in younger patients, beta blockers are associated with significant reduction in the cardiovascular mortality and morbidity. So this remains a bone of contention. This remains a point of discussion, that uncomplicated hypertension, younger patient, should you use beta blockers as the drugs of first choice? And why is that? Because basically the young and old hypertensive is fundamentally different. In the young hypertension, what you have is something which is called as predominantly diastolic hypertension, or a combination of systolic and diastolic hypertension. As the age advances, as the peripheral vessel starts getting hardened, the aorta starts getting hardened, you get non-compliant stiff arteries, and what you start seeing is a severely elevated systolic blood pressure and normal or near normal diastolic blood pressure. So there is a difference between blood pressure in a younger population and older population. Not only that, from our own data, whatever little data exists from India about hypertension, we know that a lot of our young population, and we are a very young country. Prime Minister Modi in all his speeches keeps mentioning that we have a very large young task force and we are going to rule the working class. So you see that the incidence of hypertension in this young population is quite significant in India, which approaches almost 30 to 35%. So if you have such a large young population, we need better drugs which can work in this population. And as I showed you in the beta blocker meta-analysis, younger patients still benefit by beta blocker, although not well represented in trial, and guidelines do not support this. Not only that, we also see that the mean heart rate of random population, this is a study of normotensive, hypertensive, white coat and masked hypertension. So almost 18 or 19,000 patients studied in the Indian heart study. And what you see here is that our mean heart rate is above 80 beats per minute. So we have, not only we have more young hypertensives, we also have higher resting heart rate. And that could be because of our lifestyle. We don't exercise regularly. Our diets are changing. Obesity is increasing. There is central obesity. So our heart rates, resting heart rates, generally as a population are on a higher side. Dr. Shah showed you this, and in fact, he showed a little more data on this, that as your resting heart rate increases, the incidence of coronary artery disease, cerebrovascular disease, and all-cause mortality increase. And this is in a healthy population. So if in a hypertensive, if you have higher heart rate, it is likely to contribute to increased mortality and morbidity. However, the data is not clear. If you reduce heart rate by pharmacology, can you really reduce mortality and morbidity in healthy population? So the question comes, should we use beta blockers for young hypertensive patients at all? Guidelines, as I said, do not recommend use of beta blockers. Although they are based on atenolol, they have no data for the newer beta blockers like metoprolol, bisoprolol, nebivolol, and carvedilol. There is a paucity of data, and therefore we are unable to give any concrete recommendation in young hypertensives. Newer beta blockers technically are different than the old beta blocker of atenolol, and dysglycemia with newer beta blockers could be less. But we should always keep in mind that if when we combine a beta blocker and then a diuretic on top of it, we run a significant risk of inducing dysglycemia and diabetes, especially in our South Asian population where metabolic syndrome is very high. So in our population where central obesity is there, where metabolic syndrome is high, we should not be adding up to the insult by combining beta blockers and diuretics and inducing diabetes in these patients. Having said that, there is an interesting thing which I want you to know. The Hypertension Canada is a very, very active hypertension society, and they, unlike all other societies which publish their recommendations and guidelines once in every 3 or 4 years, these are the Hypertension Canada guidelines of 2020. So they have the guidelines coming every year. And interestingly, what you see is that it is just like the old guidelines, and it includes beta blocker as a first line therapy. With a caveat that beta blockers should not be used as a first line therapy for people above 60 years. That clearly means that you can use beta blockers for people who are younger than 60 years. And these are the details of the treatment. So it says that in diastolic hypertension, with or without systolic hypertension, you are justified using beta blockers in younger population. So that is one piece in favor of beta blockers. Now, as you go from uncomplicated hypertension to complicated hypertension, that means you have arrhythmias mostly in form of atrial fibrillation, you have angina, you have heart failure. This is called as complicated hypertension, or extreme increased sympathetic activity, which we discussed after Dr. V.T. Shah's lecture. The recommendation of beta blockers comes from 0% to 100%. So all the guidelines recommend beta blockers as a first line therapy in heart failure, in angina, in coronary artery disease, in atrial fibrillation, and where you want to control the heart rate. And this is across the board. So how and why beta blockers work in complicated hypertension? A drug which should work in complicated hypertension and should not work in uncomplicated hypertension, that does not really go well in. So what is the reason? So probably it is due to the metabolic side effects of the drugs that outweigh the benefits of the drug in uncomplicated hypertension. Beta blockers with diuretics, I mentioned, especially in Southeast Asians and South Asians, we have higher prevalence of metabolic syndrome, and it can be leading to more diabetes. Atenolol-like drug can increase peripheral vascular resistance. Of course, this will not apply to drugs like bisoprolol, carvedilol, and nebivolol, that they will increase peripheral vascular resistance, but they will increase the central aortic pressure and cause higher incidence of stroke. So that's probably the reason. So there is another indication to use beta blocker, which is guideline supported, is you in resistant hypertension. Now, what is resistant hypertension? Resistant hypertension is hypertension where you have already used 3 classes of drugs, one of which must be a diuretic in full recommended dosages, and yet the blood pressure remains uncontrolled. And there, the European guidelines do recommend use of beta blockers and they specially name bisoprolol here because there is some data of bisoprolol in this area. And resistant hypertension is not uncommon. In our own population, we have the incidence of resistant hypertension, which is close to 10 to 20%. This is from the Jaipur Heart Watch study. This is a study, or this is a group of studies actually Dr. Rajiv Gupta is doing for years in the area of Jaipur and around. And they have shown that 1 in 5 individuals in Jaipur Heart Watch had resistant hypertension, meaning thereby he'll need beta blockers. Now, we discussed about the older beta blockers and newer beta blockers. And the real question comes, why should we extrapolate the data for atenolol to other beta blockers who have additional vasodilatory properties? So, as I mentioned earlier, their properties are different. They may be beneficial. Their blood pressure controlling ability is good. They have controlled the blood pressure very well in short-term studies. There are short-term studies. There are studies for 6 months to 9 months to 1 year with all these newer beta blockers. But unfortunately, for a disease like hypertension, what we need is a long-term data of 5 years, 10 years. And unfortunately, there is no data. And I don't see any trial doing or getting this data in short while. So it is only from areas like ours, we'll have to get our data. What happens is we keep using different forms of strategies in our clinical practice. And then we say that our experience with this strategy is good, but that does not work. And most of the experts across the world will say that you must show long-term beneficial data to say that. But this is supported by some of the literature, like Cochrane review. This is a review which does for various drugs intermittently, and this was published in 2016. It says that further research should be there, which should be high quality and explore between different subtypes of beta blockers. So we have not written of beta blockers in treatment of hypertension. We are just trying to palpate and get more data on the so-called vasodilatory beta blockers, which can help us to treat hypertension better. In fact, Dr. Venkatram, most of you must have heard him somewhere or the other, also wrote this in 2010 after that initial controversy which broke out in 2005 about the beta blockers. And he also mentioned that traditional beta blockers and vasodilatory beta blockers could be different because their peripheral vasoconstriction and heart rate reduction, these properties are different. So we are still open to this, but we are waiting for data, and the guidelines, except for the Canadian Hypertension Society guideline, does not support this. Now that brings me to another question. What do I do if I get a patient who is well controlled on atenolol? Patient has been taking atenolol for years, and now the patient has come to me. For sure, I know that atenolol is not the best of the beta blocker as of now, as we understand, but the patient may be reluctant to change. My approach would be to try and switch him gradually. So sudden stoppage of beta blockers in these patients is never going to be good. So you may reduce the dose of atenolol to half and add other beneficial drug like an AC inhibitor or an angiotensin receptor blocker or a calcium channel blocker while reducing the dose, and then switch it fully with AC-CCB combination or ARB-CCB combination. A small dose of beta blocker may be required to control a sympathetic overdrive which was being controlled for atenolol by atenolol for so long in these patients. So finally, I think those were some of the issues which came to my mind. Those were some of the questions that came to my mind, and I tried to sort of search answer for that. So where do we put beta blockers in management of uncomplicated hypertension in 2020? The data certainly does not support use of beta blockers in uncomplicated hypertension, especially above 60. Below 60, some guidelines like Canadian guidelines do support use of newer beta blockers. However, we also must remember that the most of the data comes from monotherapy while we are in an era of combination therapy today, and our dominant drug to treat hypertension could be a CCB and then add a small dose of beta blocker, which may not be an entirely unjustified policy. Metabolic derangements need to be monitored, but most importantly, we have calcium channel blockers, ACE, ARBs, diuretics, and their combinations, which are freely available. and they are cheap, and they are much better documented drugs for treatment of hypertension as of now. So I think beta blockers are important, but we should not be using them as a first-line therapy to treat uncomplicated hypertension as suggested by guidelines. Because the guidelines ultimately, this is the gist of the literature existing at that particular time, and they have gone through all the literature and they come out with some kind of recommendations. You may not agree with guidelines at times, but this is the fact of life. So thank you so much. Thank you, Dr. V.T. Shah, once again for your invitation. And thank you, IMA Mumbai chapter, for letting me participate here. Thank you so much.
Yeah, thanks, Niteen, for that wonderful review of beta blockers in hypertension. The reason why I was keen to add this is to emphasize that in olden days we used to start with atenolol in hypertension, and many of our senior practitioners they still by habit write it down because of the comfort it gives to them for treating these patients. But I think now people should shift to other ARBs, ACE inhibitors, and calcium channel blockers. And as you rightly said, that combinations are now available. See, combinations of other drugs. Not only this, now there are combinations of ARBs plus the newer CCBs which reduce the heart rate.
Absolutely, absolutely.
So we have ARB combination with cilnidipine or with ephonodipine and so on. So I think we can avoid using beta blockers in uncomplicated hypertension. But complicated or uncomplicated, unless you investigate, you're not going to know. So the first thing what possibly you should do besides treating hypertension initially with either CCB or ARB or a combination, and then try to investigate whether he fits into complicated or uncomplicated. I think Ajit, you have to add something.
No, actually Niteen covered everything very well. The only thing is when we are talking about complicated hypertension, the way beta blockers act is not through their antihypertensive action. Say, for example, in heart failure, they act through a different mechanism. So in coronary artery disease, they reduce the myocardial oxygen demand and they act. So it's a completely different mechanism of action by which they act in different complicated situations. So when you have uncomplicated hypertension, where in absence of other conditions, as we have already discussed, then the question, the role of beta blockers may be questioned in that situation because of the data which is available.
No, and there are sometimes occasions where patient comes with blood pressure high and a pulse rate more than 100. So many times we find it, and in such situations, what I generally do is that at least give them the routine antihypertensive along with what, as you said, a small dose of beta blocker. Maybe as time progresses, you can get rid of beta blocker at all once the blood pressure is under control, his anxiety is under control, and he feels better. So at those situations, maybe you can add a small dose of beta blocker temporarily, especially the newer ones. Bisoprolol or carbidiol also is a good drug which reduces both pulse rate and vasodilatory action. Dr. Avhad, are there any questions there?
So one question you already answered, which beta blocker is the best for controlling hypertension? Can we use anxiolytics like amitriptyline or something to take care of anxiety? To reduce the heart rate.
Yeah, I think anxiety is a major contributor, and especially if you have high normal or just stage 1 hypertension, where it's a young individual with a lot of stress that you can judge from the history, and that is contributing. But you need to follow this and monitor these patients so that you must confirm that with anxiolytics, the blood pressure is coming down into the normal range. And you can very well take 6 to 8 weeks to monitor these patients to confirm a presence or absence of hypertension. These days, you can also use what is called as ambulatory blood pressure monitor and monitor the blood pressure, sleeping heart rate, and conclude whether he has only anxiety or anxiety going into hypertension and then maybe use. To a thing that Dr. V.T. Shah mentioned, you get a hypertensive with very high heart rate. I would also advise you to investigate little bit on the cardiac side, because heart rate is like fever. It can be high because of anything. So the most important thing is to rule out a subclinical LV dysfunction in these patients, and therefore you must look at ECG, take proper history, and maybe an echo to document that the LV function is normal. And once you do that, then you are free to say that this increased heart rate does not have any obvious reason which I should be treating.
See,
that would be my approach.
Yeah, another point is, heart rate is always high when the patient comes to the hospital, to your clinic. That is because of anxiety. With the newer data which is coming on home blood pressure and ambulatory blood pressure, which is now considered to be a better way of monitoring, hypertension rather than the clinic clinic blood pressure recording, the importance of heart rate would probably be different. It has been adequately documented that the blood pressure which is taken at home is more representative of your cardiac load or even in terms of outcomes. Similarly, the heart rate which is recorded at home is clearly different from what is recorded in the clinic. So I think as more and more people will start monitoring their blood pressures at home, and rightfully so and scientifically so, the importance of heart rate will also change in those cases.
Yeah, I think, and what I do is I ask them to make a chart of it. Yes. Don't just remember, because it has to be documented, date, time, and the readings, so that it becomes very easy for a clinician to have a look rather than patient telling that everything is normal.
So 5 years ago, when patients used to say that, Dr. Mazhar, my blood pressure is very good at home, why does it increase here in your clinic? I used to say that he's probably not taking the blood pressure correctly or whatever. But now, with this new data coming, you have to believe probably what they do it at home is probably more correct.
It's more correct and more appropriate.
So I think that's going to be the way of future.
Sir, one last question.
Yeah. Yes.
Many cases have increased heart rate and 24 hours monitoring show many ectopics. Can ivabradine be given in such patients?
Okay, so basically, actually, ivabradine is for only sinus node tachycardia or whatever higher heart rate from sinus node, not from any ectopics, not from the atrium, not from the ventricle, or from the nodes, AV nodes or another. So ivabradine is not indicated in that. The only problem with ivabradine, which was shown in the study, was increased incidence of atrial fibrillation. So actually, we try not to give an inappropriate indication of ivabradine also at the same time. Otherwise, it might increase the incidence of atrial fibrillation, especially in elderly population where atrial arrhythmias are more common. So not in ectopics. Yes, beta blockers, of course, yes, they would help in both atrial and ventricular ectopics otherwise.
Thank you, sir.
So shall we go on to the next?
Hey,
excellent. Dr. Niteen, please stay and contribute to the rest of the lectures. We have something interesting now. I request Dr. Ajit Bhagwat to give his talk.
How do I share my screen?
Samir,
because
can you show his slide? This is Dr. Chafekar. Yeah. So yes.
Left hand side, sir, plus sign is there. Bhagwat sir.
Yeah.
Yeah. If you click on the plus sign, there is a fourth option is a share screen.
So Dr. Ajit Bhagwat again has done his cardiology from Nair Hospital. Practices in Aurangabad. He is director of the cath lab over there and very astute clinician, more than 25 years now in practice. And a very good orator. So we are going to hear today from him. See, what I noticed is there are plenty of webinars on heart failure with reduced ejection fraction and too less on preserved ejection fraction, or the concept of preserved ejection fraction is many times not known. So to avoid that confusion, I thought we would put up this topic of preserved ejection fraction and what is the current management or how does it look like. So for that, I gave this topic to Dr. Ajit Bhagwat. So Dr. Ajit, please, we can see the screen loading.
Well,
Sir, below that there is a small pop-up is there. Just click on that pop-up and share button is there. Click on the share button.
Oh, okay. Yeah. Well,
Sir, in the pop-up,
yeah.
the entire screen, yeah.
Now,
Yeah.
is it okay now?
Just minimize.
Yeah,
sir,
so yes, it's coming.
yeah.
Very
So
good.
perfectly, yeah.
Yes,
Can you see it now?
yes.
Yes.
Okay. So at the outset, let me thank the IMA Mumbai and Dr. VT Shah for inviting me for this very interesting meeting with a lot of very basic run-of-the-mill day-to-day topics. So the topic.
Ajit, let me tell you, more than 500 people have logged on for today's meeting. So all the more.
Great. That's really great. So the topic which I would be talking about is heart failure with preserved ejection fraction. Now, this is one area where, as a physician, as a cardiologist, you face a lot of frustration when you're treating these patients, because these patients are very sick, they are very symptomatic, and there is very little that you have in your armamentarium to make them feel better as well as to make them live longer. This problem is very important, extremely common, but very, very difficult to treat. So let me, in next few minutes, I would try to present what we know about this disease as of today. Until 1960s and 70s, heart failure was considered as it was labeled. It was given. This label was used for any patient.
Please enable your video.
Bhagwat sir, kindly enable your video.
Is it okay now? Is it okay now?
It's coming. It's coming now.
Can you see the slide?
Yeah, we can see them.
Okay. So, can you see the slide moving?
Yes, it's moving now. Good.
Okay, all right. So basically, what I said was, in early 60s and 70s, heart failure was synonymous with poor left ventricular ejection fraction. But then in 1980s and onwards, this concept of heart failure with preserved ejection fraction came up, where a number of clinicians, number of echocardiographers, number of nuclear physicians, they came up with this observation that number of people have exactly the same features of heart failure, but the ejection fraction is normal. And then this particular clinical entity was investigated further and was labeled as diastolic heart failure. Now we'll see, what it really means. Now I made this slide to make everybody understand what this diastolic heart failure is. This is just to make it, in a simplified manner, to just explain it in a simplified manner. I know most of the audience today is physicians, so I would just like to explain this. Now, imagine you have two balloons. One is a regular balloon and another is a stainless steel balloon on the right side. Now you put 500 cc's of fluid in each balloon. Now what will happen is that the regular balloon will distend, and what will happen, the pressure inside the regular balloon will be much lower as compared to the balloon which is made up of stainless steel. Now why does it happen? Because this particular balloon is distensible. It can distend like a normal heart, while this particular balloon is a stainless steel balloon, so it cannot distend, and the same amount of water will exert more pressure on the wall of this balloon as against the wall of a regular balloon. Now our normal heart is not only distensible, but it also has a property of relaxing actively. Now relaxation and distensibility are two different things, and both are present in our normal left ventricle. This relaxation of left ventricle is a energy dependent active process. So what happens is when the normal heart receives blood, it not only distends, but it also welcomes that blood by actively relaxing, and thereby the pressure in that heart, in the normal heart, would be lower as compared to any heart which for whatever reason has become stiff like a steel balloon, where the pressure would be higher as compared to a regular balloon. I hope I have tried to make this clear. So now when you have higher pressure in this less distensible stiff balloon or a stiff heart, that particular pressure is transmitted to the lungs, and that results in production of symptom of dyspnea and subsequent other features of heart failure that we'll talk about. Now, what makes the left ventricle stiff? The mechanisms could be many. It could be hypertrophy, it could be infiltration by diseases like amyloid or hemochromatosis, or it could be fibrosis, it could be abnormalities of cardiac microvasculature. It could be a number of mechanisms which can make the heart stiff, which results in what we call as diastolic heart failure or heart failure with preserved ejection fraction. Now, it is important to remember that this particular syndrome of heart failure with preserved ejection fraction, it encompasses a heterogeneous group of patients. It is not very simple as heart failure with reduced ejection fraction. This particular HFpEF, I will call it HFpEF in my lecture here onwards, heart failure with preserved ejection fraction. So HFpEF patients, in these patients, a number of associations exist. And these associations are with many other diseases. And what are these diseases? One is a couple of things: age, elderly people, and more common in females. And the disease entities which are associated with HFpEF are obesity, which is in number of series have been associated with HFpEF in 70 to 90% of patients. It depends on how you define obesity. Hypertension is about 80%, diabetes 20 to 40%, CKD about a quarter, metabolic syndrome, obstructive sleep apnea, and rarely infiltrative disorders like amyloid, hemochromatosis. So the most important thing that one must remember is a patient of HFpEF. When you see him, he comes to you with a number of other comorbid conditions, and that is why you have to suspect HFpEF, because sometimes an obvious diagnosis is very difficult. You have to suspect it before you can clearly diagnose it. So suspicion is very, very important. Now, a slide on obesity, simply because it has got some special features. Now, most often obesity, it is very commonly associated with HFpEF. It is also associated with hypertension and diabetes, metabolic syndrome, obstructive sleep apneas, Now, when the patient has obstructive sleep apnea, it's very difficult to say whether this patient has breathlessness or symptoms because of OSA or because of heart failure. Now, obese patients have lower BNP levels as compared to non-obese patients. So that confounds your diagnosis, that complicates the diagnosis. And because obese patients are little difficult to assess clinically, they have short neck, sometimes they have edema on their feet for various reasons, they're taking medicines, and assessment of volume status becomes a little difficult in these patients. So when you see a obese patient, particularly a significantly obese patient who comes to you with breathlessness, HFpEF should be high on the list as soon as the patient enters your clinic. Two things you must think about: this HFpEF and obstructive sleep apnea. When you see an obese patient who comes to you with a predominant symptom of breathlessness. Now, this slide tells you a number of things. We'll dwell upon this slide for a minute or two. At the top, we have risk factors for HFpEF, which are aging, obesity, metabolic syndrome, as I already said, hypertension, sedentary habits, and then coronary artery disease, kidney disease are associated features. Now, what happens at the tissue or cell level? This results in systemic inflammation, myocardial ischemia, tissue fibrosis, abnormal myocardial energetics, altered cell signaling, and myocyte hypertrophy. So because of these things, number of changes are taking place in the myocardial tissue at the cellular level. And this results in marked dysfunction in the cellular function. Now, this need not necessarily reflect in reduced ejection fraction, but sometimes in early stages or in the entire spectrum of the disease, it only reflects in the diastolic phase of the heart. Now, what are the structural remodeling, type of remodeling that can occur? This is a normal heart, then you can have hypertrophy, then you can have chamber hypertrophy as well as chamber dilatation, or you can have a dilated chamber with a large heart. Now, what happens to the functional reserve of the left ventricle? There is decreased inotropy, decreased lucitropy, and decreased chronotropy. All this can happen, which results ultimately in LV filling, increased LV filling pressures and decreased organ perfusion. Now, it is important to remember that diastolic heart failure or HFpEF is not a disease which you can, just say that restricted to the heart. It has got its effect. They go at the periphery very significantly. And we'll see how. These are the secondary organ dysfunctions which are seen in patients with HFpEF. One is lung congestion. Second is left atrium. Now, left atrium is something which is very important when you're assessing patients of HFpEF. My friend Niteen Burkule calls left atrium as HbA1c of diastolic LV diastolic function. By assessing left atrial function, you can tell a number of things about left ventricular diastolic function. Then it also has effects on pulmonary hypertension because of increased, say, pulmonary venous pressure. Pulmonary hypertension also goes up. And important thing is effects on skeletal muscles, peripheral skeletal muscles in your extremities and other areas where you see sarcopenia. You have significant reduction in sarcomeres which are seen in patients of HFpEF in their skeletal muscles. So basically, LV remodeling and dysfunction in the heart associated with a lot of changes at the peripheral level results in clinical syndrome of HFpEF. So it's important to remember this. Now, what happens in the hemodynamics? I'm going to quickly go over it because it is important. In patients with HFpEF, which are depicted here in the red, you can see that as the person starts exercising, the pulmonary capillary wedge pressure goes up very quickly as compared to a normal person, which is here in the black. So that is why these people get breathless very quickly. Their LVD, left ventricular end-diastolic pressure, is high at the baseline many times. If you exercise, it goes up very quickly because the pressure curve is moved. It has moved to the left and above. So that is one. Number two, for every 1 liter, for every unit increase in cardiac output, the increase in pulmonary artery pressure goes up very significantly. This is a reflection of pulmonary wedge pressure itself. The same thing happens with respiratory rate. What happens is these people have the immediate effect on the ventilatory drive also as the patient starts increasing the exercise. So they feel that increase in the ventilatory drive is perceived as breathlessness along with increase in wedge pressure. So it's a combination of increased ventilatory drive and increased wedge pressure, which makes them feel breathless. So these are the three most important things. We can actually, for the time being, we may not talk about the lower three slides. Now, what are the clinical features of HFpEF? Now, for all practical purposes, one should remember that the clinical features of HFpEF are no different from the clinical features of HFrEF, that is heart failure with reduced ejection fraction. The patient would present with the same symptoms and similar signs. The only difference would be in reduced ejection fraction patients, you will find something like a third heart sound, left ventricular third heart sound, which is very rare in patients with HFpEF. If you hear a third heart sound, clinically, you are probably dealing with patients with a dilated heart with reduced ejection fraction. But otherwise, most of these patients have same features. Patients with HFpEF will have clinically a loud fourth heart sound, or what is called a S4 gallop. That is more common in these. But otherwise, the clinical features are the same. HFpEF accounts for almost half the cases of heart failure. Very common. And the clinical features result from increased LV filling as well as from fluid retention. Now, as I mentioned again, HFpEF should be suspected first. Many times patients come to you with symptoms and you have to look for a cluster. I always think that heart failure with HFpEF patients, they present to you in clusters. Now those clusters could be a breathless patient who has preserved EF, but he has diabetes, hypertension and dyspnea. Hypertension, a female hypertensive patient who is feeling breathless and features of some heart failure. Obesity, hypertension, heart failure. Hypertension, atrial fibrillation, breathlessness. Obesity, heart failure. So these are clusters which will come to you in your clinical practice, and you will have to suspect heart failure in these patients. And as I told you, sometimes because these patients are many of these patients are obese, clinical features are little difficult to diagnose or to see in these patients. Now, these are the three most important things based on which you make a diagnosis of HFpEF. One is symptom of exertional dyspnea. Second is left atrial enlargement or dysfunction on echo. And the third is elevated biomarkers. Now, there are a number of definitions, how to diagnose heart HFpEF. There are a number of criteria which have been put. I don't want to get into those details because there's a lot of theory involved there. But I think for all practical purposes, these three are most important. Features of heart failure, left atrial enlargement, and elevated BNP. Now, if the patient has florid heart failure, you don't need anything. It's very obvious. But sometimes patient comes to you with very marked breathlessness, class 3, class 4 almost. Clinically, you don't see, fluid overload or bloating, but then you see a little bit of left atrial enlargement and elevated BNP, and then you have your diagnosis of HFpEF. Now, what is the workup? Now, echocardiogram is the most commonly used diagnostic modality. Now, I don't want to get into this because you can. There are books written on echocardiogram to assess diastolic dysfunction, and then there are expert echocardiographers who can talk for 1 hour on only this topic. I don't want to get into that. That's not the purpose of today's topic. But suffice it to say that echocardiogram is a very vital tool in assessing diastolic function in these patients. But remember that 10% of patients who have got diastolic or HFpEF will have no significant abnormality seen on echocardiogram. Now, there is no sine qua non of heart failure, HFpEF on echo. There could be number of things, echocardiogram features, which you can put together and they would add up and they would help you in diagnosing HFpEF. You can do cardiac MR if you are suspecting infiltrative disorders or some myocardial primary structural disorders. You can use that. And one must rule out coronary artery disease in patients with HFpEF, particularly if they have risk factors for coronary artery disease. So these are few important things as far as the diagnosis is concerned. What is the prognosis? The prognosis is pretty bad. Prognosis is as bad as patients with HFrEF. Almost, it depends on the age, but as the patient is, you can see that the older the patient, the worse is the morbidity and mortality. Now, at the end, I would like to come to the treatment part. As I said at the beginning, that the treatment is quite frustrating and difficult. Now, as far as symptomatic relief is concerned, if the patient is markedly symptomatic, you have to give the patient diuretic. Now, these patients are very sensitive to effects of diuretics because they need higher filling pressures for maintaining cardiac output. Now, if you give them diuretics, their filling pressure would go down, their dyspnea would reduce, but then they come back to you and tell you that they are feeling extremely fatigued. And that the reason is their cardiac output goes down. And sometimes their urea creatinine goes up because of that. They get pre-renally exotemic. Now, so use of diuretics in these patients is pretty tricky and sometimes difficult. But let me tell you, sometimes you have to keep these patients asymptomatic. You have very, very little drugs to use. So in these patients, you have to use diuretics sometimes at the risk of keeping their urea and creatinine high. I have a few patients in my practice whose baseline urea creatinine is like 60 and maybe 1.82. But if you reduce the dose of diuretic, their urea creatinine goes down, but they become very breathless. So, symptomatic relief for these people is extremely important. There is no drug which has been shown to prolong survival in these patients. We'll talk about the TopCat trial in the next few slides. Now, Dr. V.T. Shah and Dr. Niteen Deshpande we have talked about beta blockers or CCBs to reduce heart rate. Now, to reduce heart rate in these patients is important because you prolong diastole, you give more time for left ventricular filling, so that their cardiac output is maintained. So, it is important to prevent or avoid tachycardia in these patients and keep their heart rates within 60-70 range in these patients of HFpEF. Now, this is an important trial. This was a TopCat trial, which is talked about a lot in these patients. There were about 400 patients, more than 60, EF more than 45%, and NYHA class 2 to 4 were randomized, either to spironolactone versus placebo. Now, the primary outcome which was assessed was death, heart failure, hospitalization for heart failure, and aborted cardiac arrest. Now, there was a big controversy in this trial. About 51% patients were from US and 49% patients were from Georgia and Russia. Now, when they studied these patients separately, they found that the outcomes were entirely different in Russian patients. And the endpoint was 4-fold lower in Russians. So there was a number of doubts raised about the enrollment of the patients in Russians, whether they were followed properly, whether the drug was given properly, because when they assessed only US patients, it was found that spironolactone was significantly better as compared to placebo. So based on this trial, despite this big controversy, AHA ACC classified use of spironolactone as 2B in treatment of HFpEF. So this is one of the drugs which we may use, and probably with the hope that it improves survival in these patients. Now, this was another trial which came in October 2019. This was a Paragon heart failure trial where ARNI, that is sacubitril valsartan, was tried in patients with preserved ejection fraction. And again, about 5,000 patients, EF more than 45, same NYHA group. But in addition to that, they had elevated BNP. They were randomized either to sacubitril valsartan or to valsartan alone. And the endpoint was composite of death or heart failure. And at the end, they found that there was no difference in the primary outcome in these patients. However, two groups of patients, one was females and second was people whose ejection fraction was on the better side, like above 45%, 45 to 50, like we call it borderline heart failure, those patients benefit much better. Actually, it should. This is wrongly placed. This should have been at the top. They did much better as compared to the other patients. So, in subgroup of patients who have got a little better left ventricular ejection fraction, like 45 to 50, not little better, I would say, a little lower in ejection fraction as compared to people in that group, and females, they do little better. Now, in this clinical trial, hypotension was much more commonly seen in people with sacubitril valsartan. The difference was very significant, and this is little expected in these groups of patients because their ability to increase the cardiac output is very, very limited because of their reduced filling. Now, this was one interesting trial which looked at exercise training in older patients with heart failure and preserved ejection fraction. This was published in Circulation, and it was a randomized, controlled, single-blind trial. And in this, what they saw was when the patients were given about 4 months of supervised exercise training, their peak VO2 consumption capacity, exercise capacity, was significantly increased as compared to the control. So, non-pharmacological therapy is also important in these people, and then that the form should be exercise training, supervised training. So the conclusion of this trial was 16 weeks of supervised exercise training was safe, and it significantly improved peak and submaximal exercise performance in older patients with HFpEF. These results suggest that this non-pharmacological intervention may be worthwhile to consider in patients with this common and increasingly prevalent disorder. So lifestyle modification is important, like exercise training, caloric restriction, and to some extent salt restriction. There is limited data on this. So in conclusion, HFpEF represents a heterogeneous group of patients. The prognosis is as bad as HFrEF. Clinical features are similar, but the heart failure is relatively preserved. It has got cardiac as well as important peripheral components. Diagnosis is made by presence of clusters, which you see in your practice. Treatment options are limited. Diuretics, spironolactone, and ARNI are useful in some subgroup of the patients. And there are some important ongoing trials with SGLT2 inhibitors, which are awaited because it is some people expect that they would be positive. So we'll have to wait for those trials results to come out. So thank you very much for your patient hearing. If there are
Yeah, so thanks, Dr. Ajit, for that wonderful coverage and the example of a balloon to stress upon how to understand what is reduced ejection fraction and what is preserved ejection fraction. So now, as far as the general practitioners are considered, for them, what is more easy to perform a test is, I think, a blood test of pro-BNP or BNP. Because to get an echo done nowadays in this COVID era is a bit difficult. And the most important thing is that with this COVID, the symptom of breathlessness is so common that almost 50% of the patient coming with fever, if he says breathlessness, then they feel that. So what do you think, how would you interpret pro-BNP in this COVID pandemic? Would it signify a symptom of heart failure? Whether it is reduced or preserved is on echo. But at least if it denotes heart failure, then they know on which track to go. What do you think in COVID, the pro-BNP levels, how are they?
Well, I'm not too sure about the pro-BNP levels in COVID patients without any cardiac involvement. I'm not aware of that data. But as far as I know, COVID had changed our practice so much that now, in every symptom interpretation, the first thing is, could this be COVID? That comes in your mind. It may be chest pain, it may be palpitations, it may be breathlessness. But many times it is just anxiety. Patient comes to you with anxiety. He just says that I'm just not feeling right, and you suspect that this is anxiety, and it turns out that the patient is COVID positive. So that shakes your confidence also. That you are probably missing some patients as well. So coming back to your question, I think diagnosis of HFpEF should be, as I always stress, that it should be suspected first. It's a question. If you see any patient who has diabetes, hypertension, who is obese, who has got CKD, who comes to you with breathlessness. Now, I'm not taking COVID into account here. I'm talking in general. Make sure, you should think about HFpEF, because as I told you, 50% of patients with heart failure have HFpEF, almost half of them. So what happens is, as the first thing, we send the patient to an echo lab. Patient goes and comes back to you with an echo report saying that ejection fraction is 55%. And then the entire diagnosis of heart failure is out of your mind, unfortunately. And there you miss the boat. And then patient is investigated for something else, for lung disease, and then sometimes labeled as functional and given depressive therapy. And unfortunately, what he has is HFpEF, which is not eminently curable, but there are a number of things you can do for the patient. Investigate him properly, give him some medicines which could be useful. So my message would be, you suspect heart HFpEF in your clinical practice. Whenever you see a patient with breathlessness, if a patient comes to you with breathlessness, look at his physique. Is he obese? Does he have hypertension? Does he have diabetes? Does he have CKD? Just even if his LV ejection fraction is normal, you can say, well, that's okay. This patient still can be heart failure. So that should be the message. That should be something which everybody must remember.
Yeah, very important, Ajit. You stressed upon that whenever, as a physician, you look after the echo report, please just don't look at the ejection fraction. There is always a column down below which says Doppler. So what are the Doppler? Does it say that there is diastolic dysfunction? That also you should look for. So besides the ejection fraction, look at the diastolic parameters which are given over there. See whether there is raised pulmonary artery pressure or not. So all these things one has to look. And when you send for an echo, please see that you get all these parameters in hand to diagnose besides a pro-BNP level. But one thing is sure, Ajit, do you think that once we say that the BNP or pro-BNP is normal, at least it will rule out diastolic or preserved ejection fraction heart failure?
Well, if it is completely normal, we can say it is unlikely. But you must remember that there is a big subset of patients who have got normal filling pressures at rest. But when you put them on treadmill, their left ventricular end diastolic pressure goes up steeply, as I showed you in one of my slides. So don't rely only on the BNP or only on resting indices of left ventricular diastolic function. Sometimes things can go abnormal as soon as they start exercising. So my suggestion would be high index of suspicion. Get help of a good cardiologist who you really trust in. Make sure that you send the patient for echocardiography to a cardiologist who can study diastolic dysfunction. Remember and mind well, it is not easy. You have to spend a lot of time. A cardiologist has to spend a lot of time in assessing diastolic dysfunction. So ask him right question. And even if he says that at rest the diastolic dysfunction is normal, don't rule out the diagnosis of diastolic heart failure very easily. Persist with it until you are convinced that this is something else, and you can explain his symptoms based on something else.
And one of the important things to be excluded, of course, is coronary artery disease.
Absolutely. I mean,
in a high risk diabetic, hypertensive, CKD, you have to rule out an obstructive coronary artery disease as the cause of diastolic heart failure. So that would be very important in day-to-day practice.
Rarely, I did not mention it, but the pericardial disease, that's one of the rare causes of frank diastolic, heart failure. and that is an eminently curable cause. Make sure that you are not dealing with pericardial constriction, which once in a while you will always see, and the patient will bless you throughout his life if you diagnose it and cure him of that disease.
Yes. Dr. Avhad, any questions on the chat box?
Yeah,
we
yeah.
see Dr. Chafekar
Yeah,
joining
sir.
us. So,
Yeah, 2 questions, sir.
Yeah.
Any role of SGLT2 inhibitor and ARNI in heart failure with preserved ejection fraction?
Yeah, I mentioned it. ARNI has some role in some subset of patients, particularly women and people who have got borderline LVEF, 45 to 50%. There, the trial showed that they helped this subset of patients. You may be justified in using ARNI in these patients. And number 2, the SGLT2 inhibitor trials are awaited. We should get the results soon in near future.
yeah,
Sir, one
in
more
a year
question.
or two, in a year or two, I think we'll get those. And if they turn out to be positive, in the sense effective, I think that will be a big game changer in the treatment of diastolic heart failure.
That is true.
Especially because in reduced ejection fraction, both in diabetic and non-diabetic population, they have shown to be effective. So if the same proves to be true in diastolic heart failure, both in diabetic and non-diabetic, then I think it will be a big revolution.
And it is important to remember that every patient who has got heart failure with reduced ejection fraction has diastolic dysfunction along with it. So it's rarely only systolic dysfunction. So people with reduced ejection fraction also have diastolic heart failure along with it. So those drugs would be really be a game changer.
Right. Another question?
So there are reports dapagliflozin is useful in heart failure.
Yes. Dapagliflozin is now DAPA heart failure showed that dapagliflozin, when used in heart failure with reduced ejection fraction, improved outcomes, primary outcomes in patients over and above the standard recommended treatment of beta blockers, MRAs, and even ARNI. So it is very important to remember the results of those trials. And then after that, even the Emperor heart failure trial came, which showed the same thing. So there is no question that now you have 2 SGLT2 inhibitors, which have been shown to be useful to reduce mortality and morbidity in people who are already on ARNI and established treatment for heart failure.
Sir, last question.
Yeah.
Role of NT-proBNP as a routine investigation for heart failure diagnosis.
Yeah, I mean, it is definitely useful. There is no question that NT-proBNP or BNP levels, you see any clinical trial, they go by, sometimes their inclusion criteria have these markers for including patients in heart failure trials. So very, very important for diagnosis. It depends on an individual as to how to use them in your clinical practice. For diagnosis, it's extremely important. Whether to use it as an endpoint for treatment is controversial. Whether you should chase a number. Suppose today BNP is 2000. Should you increase the dose till you make it normal, or to make it 200, 100? We don't know about that probably. But for diagnosis, it's extremely important. No question about it.
Can I say something?
Thank you, sir.
Yeah. Can I say something?
Thanks, Dr. Ajit Bhagwat. And now we go on to the... please go ahead.
Okay. Can I say something regarding this topic?
Please, Dr. Chafekar.
Yeah, Dr. Bhagwat made a very important point in his presentation regarding he has some patients who have a rise in urea and creatinine while the patients are on treatment for the HFpEF. Now, I think all of us should understand that the judicious use of diuretics is very, very important. He already said that in his presentation. And we have to keep on changing the doses of both loop diuretics as well as the other diuretics whenever you are following up the patient. So we have also seen in our practice that the creatinine keeps on going up and down. So in this situation, my comment would be that besides monitoring creatinine, you can always also look at the eGFR in the same patient, and you will pick up fall in eGFR much earlier than the rise in creatinine, and probably you will pick up the fall in renal function earlier. And the second comment which I had is that if your patient is on an MRA And if he needs to continue on the MRA for the cardiac reason, and the patient has got mild renal insufficiency with hyperkalemia, do you use long-term potassium exchange resins because you think that MRA is very, very important for that patient to maintain his cardiac function, and the only hindrance is hyperkalemia?
Hyperkalemia is definitely a side effect of MRA, but if you really look into your experience in clinical practice, hyperkalemia, even in clinical trials, was not a great, a big challenge when you are using MRAs. If you use them properly, if the patient follows your instructions and follows up with you regularly. But I agree that you have to keep an eye on potassium. Incidence of hyperkalemia in Rails trial and FSS trial in heart failure with a reduced ejection fraction, it was not different between placebo group and MRA group. But of course, that is a clinical trial scenario. But in day-to-day real life, I have never used long-term resins to prevent hyperkalemia, at least in my practice. But if you have, and if you know any data or if you have used it, you can please share your experience.
Yeah. So
my comment on that is, you're right. The incidence of hyperkalemia possibly has now increased because of combination of giving either ARB, ARNI along with MRAs, spironolactone. There, yes, we have a problem that we do get, and we are very cautious in that. So, first of all, what we try and do is reduce the dose of MRA. Maybe if you are giving 25, you can give it alternate day, or you give half a tablet. Accommodate ARNI or ARB also in the heart failure. This is with reduced ejection fraction. So with preserved, we generally don't use ARNI or ARB unless it is mid-range or 45, as he said, 45 to 50. But long-term resin, as Ajit rightly said, with the currently available K-bind resins which are available with us, we are not using long-term. Yes, we know that patriomers are in the future going to come, but as on today, they are not available, and very few patients who are taking it's quite expensive if we have to import them. So, really expensive tablets. I don't know whether nephrologists have started using routinely, or is it available?
One important point is when I use MRA in HFpEF, as a diuretic, I always use plain Lasix along with MRA, rather than using torresemide or any other diuretic which has got little potassium sparing effect. So, using Lasix can probably offset risk of hyperkalemia to some extent.
I think the importance of diet should not be underestimated, and we have to educate the patient.
I agree.
Diet.
I missed it. I should say, very important. In few of my patients, I picked up why their potassiums were going up just because they were eating dates, almonds, and all sorts of those high-rich potassium diet, or oranges and fruits like this. Very important, Dr. Chafekar. I think you made it right. And I think the amount of the diet can reduce potassium by 1 milliequivalent at least. Is it
1
right?
to 1.5, yeah. 1 to 1.5.
Very good point. So,
and as far as the petiromer is concerned, just one last comment. There is a trial going on in Europe regarding chronic use of petiromer for patients who require MRAs, and they have shown that it can be used over a long period of time, almost 6 months, and patients have done really very well on that. I agree about the use of binding resins, which is difficult to use.
Yeah, very good. So, excellent points. That's why you see, I always say that besides a cardiac surgeon, you should have a nephrologist friend always by your side, so that he can take care of the kidneys while you are treating the heart. So for that reason, today I included, and with more and more kidney diseases occurring in heart patients, I thought it relevant that world over now CKD is taken over as a big risk factor for heart disease, and to have a talk on that topic. So we have Dr. Chafekar. We keep on meeting in many of our ad board meetings. and I was really impressed the way he approaches this topic of CKD with heart diseases. So he is also actually passed out his DM DNB nephrology from KEM hospital, practices at Nasik, but goes all around and he gets patients from all over Maharashtra for nephrology. So with these few words, I will request now Dr. Chafekar to please address this topic.
Thank you, Dr. V.T. Shah, and I must thank you for the invitation. I also want to thank the Indian Medical Association Mumbai branch and all the office bearers for giving me this opportunity to talk to you. I agree with Dr. Shah that it is a very important topic as far as CKD and association with CVD is concerned. And the title which is given by him is CKD a risk factor for CVD? So the answer in very simple terms is yes, of course it's a risk factor for CVD. But what I'm going to try and do is going to try and give you some evidence for it, as well as I will also try and address how to manage this, because I think from the management perspective it's very important as clinicians of how do you look at it from the risk factors point of view. Change hota hai. Yeah.
Yeah, now it's moving.
Yeah. So I'll just begin by saying what is the effect of chronic kidney disease on the cardiovascular system? So let me begin by saying that there's a lot of organ crosstalk between the heart and the kidney. And we as nephrologists, we keep on talking to the cardiologist because many of our patients have cardiovascular disease, and many of the cardiologists, they have issues with the kidney. So therefore, they have to take help of the nephrologist, as already mentioned by Dr. Bhagwat in his talk. So there are a lot of heart and kidney interactions. So you can say on the left-hand side of your screen, cardiorenal, that means primary problem in the heart and secondary problem on the kidney. And on the right-hand side of your screen, you can see renocardiac. Primary insult is to the kidney, followed by insult to the heart. So therefore, there is a lot of common interaction between the two organs, and it's important for us to know both in the acute situations as well as in the chronic situations, it happens that you can get organ crosstalk and you can get organ failure both in the acute and in the chronic setting. So there is something defined as cardiorenal syndrome, and there are various types. So acute and chronic, so type 1 and type 2 are called as primary cardiac, acute and chronic, followed by secondary renal. And type 3 and type 4 are primary renal and secondary cardiac, acute and chronic. So here we are going to talk about only chronic kidney disease causing problems related to the heart. I'm not talking about the type 1, type 2 or type 3 types of cardiorenal syndrome, and neither the type 5, which is the secondary cardiorenal syndrome. So we are going to talk about only type 4 type of cardiorenal syndrome, which is chronic renocardiac syndrome. Now, I already told you about the classification of cardiorenal syndrome, but that's not the main topic of today. There are a lot of mechanisms by which heart and kidney are affected together. There could be hemodynamic mechanisms, which is related to fluid overload, congestive heart failure, poor organ perfusion, and vasoconstriction in both the organs. There are neurohumoral mechanisms related to the renin-angiotensin system as well as the sympathetic nervous system. And there are some cardiovascular mechanisms related to the heart, anemia, acid-base disturbances, etc., etc. I will deal with a few of the treatable mechanisms in the subsequent slides. So, if you talk of chronic cardiorenal syndrome, which is type 4, right from CKD stage 1 onwards, so CKD stage 1 to 2, 3, 4, and 5, there is some effect on the heart. This is a very busy slide, no point in reading this, but let me just tell you that CKD stage 1 and 2 also has some mechanisms which can cause heart disease. For example, smoking, obesity, hyperlipidemia, chronic inflammation, etc., etc. If it is CKD stage 3 and 4, some other mechanisms are coming in, like anemia, uremic toxins, calcium phosphorus problems, etc., etc. And of course, in CKD stage 5 and in those patients who are on dialysis, there are other mechanisms. So in all stages of CKD, you will notice that there are some problems which can affect the heart. Now, this is a scientific statement made by the American Heart Association. Kidney disease is a risk factor for development of cardiovascular disease, and everybody agrees to this statement that CKD is a CAD equivalent, like many other, like diabetes is a CAD equivalent. So similarly, CKD is also a CAD equivalent. Now we know the classification of CKD, stage 1 to stage 5, and here I just want to tell you that whatever is the stage of CKD, you will have some problems which are related to the heart. Now, the cardiovascular events, hospitalization and death are more common in CKD, and as the GFR falls over a period of time, and if you look at the endpoints of hospitalization, death and cardiovascular disease, the mortality is much higher as the GFR falls and the stage of CKD changes. From the Framingham Heart Study, there is data to show that cardiovascular disease is again prevalent in CKD to a great extent. And there is an important study called as KEEP study, the Kidney Early Evaluation Program. Again, it showed that anemia, reduction in GFR, and microalbuminuria were independently associated with cardiovascular disease. And when all three are present, then the survival is reduced. It's important to remember this triad as far as the heart and the kidney are concerned. Remember that cardiovascular outcomes worsen with CKD progression, which is a point which I have already made. Also, if you compare the cardiovascular mortality in the general population versus ESRD patients, again, it's important to remember that in ESRD patients, the mortality is much higher as compared to the general population related to the cardiovascular disease. And the other thing which we must remember is that cardiac arrhythmias are also more common in the CKD population, almost twice the normal population. And heart failure is also more common, and already a mention has been made about HFrEF and HFpEF also. So they are more common in patients with CKD. Now, CVD represents a leading cause of mortality in patients with CKD. Remember that most of our patients of CKD, they may not die of kidney disease because they have the option of dialysis, but they might die earlier of cardiovascular disease for a simple reason that they have a lot of mortality and morbidity related to the heart all the time, and which may or may not be controllable or treatable. As the age increases, the CVD risk also increases in the CKD population also, and this remains in the kidney transplant patients as well as in patients who are on hemodialysis. So this point again has already been made, but if you look at the actual figures, if you have a patient with ESRD and if you have proteinuria, the CV risk of dying because of the problem is 20 to 1,000 times more as compared to the general population. So it is very, very serious matter. Now, having told you and having given you the evidence that CKD is definitely a risk factor for CVD in all stages of CKD, let us look at why does this occur. So there are some traditional risk factors which all of you know and which we are trying to manage in our clinical practice. So age, of course, cannot be changed, sex cannot be changed, but hypertension, smoking, diabetes, dyslipidemia, left ventricular hypertrophy, these are all modifiable risk factors which can be treated in all patients, whether it is CKD or non-CKD, and they are traditional risk factors. But there are a lot of novel and uremia-related risk factors which one should know and which are contributing to the increased mortality and morbidity in patients with CKD and related to CVD. So, for example, sympathetic overactivity, uremic bone disease, volume overload, chronic inflammation, endothelial dysfunction, anemia, vascular calcification, coagulation disorders, and progressive atherosclerosis. All these are important factors which are specifically related to chronic kidney disease and uremia, which we must remember, because some of them are modifiable and some of them are treatable. So if you have CKD stage 2 to 3, then the traditional risk factors are more important. In CKD stage 4 and stage 5, the novel risk factors are more important, and of course the traditional risk factors continue, but the novel risk factors are also very, very important as far as the management is concerned. So I already mentioned about traditional and non-traditional or kidney-related risk factors. I will not read it again, but let us look at the general management of traditional risk factors one by one as in patients with CKD, because it is clinically important. Now, if you look at hypertension, the prevalence is very, very high, almost 90%. Many of them will have LVH, and then once on dialysis, again, there is what is called a reverse causality as far as hypertension is concerned. And good control of blood pressure is going to really help the kidney as well as the heart. So what does the KDIGO recommend as far as hypertension management is concerned? Lifestyle modification, ARBs and ACE inhibitors could be the first line therapy in at least in the initial stages of CKD, stage 1 to stage 3 for that matter. Of course, after that you have to use the ACE inhibitors and ARBs very, very judiciously. We should also individualize the targets. Always look for postural hypotension in these patients, and you must tailor the treatment properly, especially in patients who are on dialysis. What are the targets? The target in the International Society of Hypertension has given a target in non-CKD patients as 140/90. But if you have a diabetic or a CKD with proteinuria, the target is lower. It should be less than 130/80. So please remember that the target of control of blood pressure is lower in these patients because you want a better result. I'm not going to discuss in detail all these factors because everything is a topic by itself. Let's look at heart failure and LVH. Heart failure and LVH, it develops earlier in CKD. Almost 75% of patients would have these problems at the time of dialysis initiation. There are other contributory factors also, like anemia, sodium and water retention, volume overload, etc., and sympathetic overactivity. And remember that we must differentiate between the diastolic heart failure as well as the systolic heart failure, but this has already been discussed previously. There are other hemodynamic mechanisms which I am not going to read out because I will discuss it later, but that they also contribute to heart failure. Now, beneficial effects of RAS blockade are important as far as therapy is concerned. Similarly, you can use sympatholytic drugs for treatment. That is also going to contribute for better management of heart failure. So you may use sympatholytic drugs like beta blocker judiciously, and the other centrally acting drugs which are also sympatholytic drugs. So in patients with hypertension and severe LVH, you can use other drugs besides RAS blockers to treat this problem. And the other issue as far as CKD patients are concerned is cardiac arrhythmias and sudden cardiac death. Please remember that incidence of sudden cardiac death is very high, especially in patients on dialysis. Half of the cardiovascular deaths in ESRD may be related to arrhythmias. And why they are more prone to arrhythmias is obviously because of electrolyte abnormalities. One of them is related to potassium. The other thing could be magnesium and calcium. These are important electrolytes which we deal with in these patients. And then changes in blood pressure, volume, hypo or hyper, etc., etc. Sudden cardiac arrest may be related to hypo or hyperkalemia and low calcium also. So these are the things which we should look for therapeutically in all these patients. Remember that whether ICDs are useful to prevent sudden cardiac death is there is no robust evidence, but all the cardiologists here who are present can comment on that. Beta blockers has already been discussed, but important thing from our perspective is to look at the potassium, both at the time in the dialysate as well as in the serum, and also look at all the drugs which will cause hypo or hyperkalemia. Again, atrial fibrillation is more common and the prevalence is almost 10%, and the guidelines are very clear as far as management of atrial fibrillation is concerned. There is some debate about use of warfarin versus NOACs. I'm not going to discuss that in detail, but if warfarin is, of course, contraindicated in a lot of patients with CKD who are on dialysis. We are using in our practice apixaban, and we get away with all the other complications related to that. The most important problem related to cardiovascular disease in patients with CKD could be acute coronary syndromes and heart failure. So acute coronary syndrome leads to almost 17% of deaths in ESRD, which can be attributed to ACS. Now, the pathophysiology could be different, and there are other factors which I will discuss later. Again, chest pain may be absent. The troponin values are problematic in patients with CKD as far as interpretation is concerned, but you have to take all the evidence together and then diagnose acute coronary syndrome. Therefore, you need a very, very high index of suspicion as far as ACS is concerned. Now, there are many confounding factors, but to treat ACS, you can use the standard guidelines. But remember that all the drugs may need some modification as far as the dosages are concerned, especially related to statins and ARBs. So a regular assessment of cardiac function is required, and you must treat the patient to the dry weight. That means dialysis should be achieved to dry weight. And of course, do a cardiac CT if you are not able to do the other investigation. But remember that there is always a problem of contrast-related nephropathy if you use large doses of contrast, and that also has to be considered. Maintain hemoglobin between 10 and 12 grams, and of course you have to treat other things like hyperphosphatemia, which I will deal later. What about dyslipidemia in CKD? Some interesting figures are there. People with nephrotic syndrome, they have hypercholesterolemia, chronic kidney disease. They have both high LDL and high triglycerides. And the other people who are on hemodialysis also have this problem. But remember that the treatment is different as far as patients with CKD is concerned. The dosages of drugs are different. So I'm not able to change the slide. Yeah, so there are many situations where you can see that the drugs are different. So whenever you have a older person with the eGFR which is on the lesser side, then most of these patients would be on statins. But a younger patient, less than 50 years, if there are risk factors, then the patient should be on a statin. If the patient is on hemodialysis, it is not recommended that you should start a statin, but he is already on a statin, then you can continue the statin. So that is the recommendation as far as use of statins is concerned. Fibrates are not really recommended in these situations because they are nephrotoxic. Yeah. Now, what are the recommendations as far as use of statins is concerned? Remember that atorvastatin, large doses cannot be used, but we recommend around 20 milligrams of atorvastatin and around 10 milligrams of rosuvastatin. But if the patient is more than 50 years old, then always the nephrology community recommends a combination of a statin with ezetimibe, for the simple reason that you are going to reduce the amount of side effects related to statins. And please remember that there are more side effects in patients with CKD as far as use of statins are concerned, like rise in enzymes, as well as some patients have myoglobinuria. So that should be remembered as far as use of statins is concerned. Now let us look at some non-traditional risk factors also, which contribute to the development of cardiovascular disease in patients with CKD. So important is CKD MBD, which is mineral and bone disease in patients with CKD, endothelial dysfunction, oxidative stress, uremic toxins, and gut dysbiosis. Now some of them are modifiable and some of them are not. CKD MBD is a very important pathophysiologic mechanism as far as CVD is concerned. Remember that vascular complication is a well-known cardiovascular risk factors in hemodialysis patients, and vascular calcification occurs because of the mineral and bone disease component as far as CKD is concerned. Now, this is not a simple deposition of calcium phosphate crystals. There is some upregulation as far as some genetic markers are concerned, and this is also contributing to an increased risk of arrhythmias as well as sudden cardiac death. So detection of vascular calcification is very, very important as far as these patients are concerned. So therefore, there are some guidelines by K. Doki regarding whether you can do electron beam computed tomography to diagnose these patients early. So if a patient is without CKD, you will see basically intimal calcification, which is secondary to atherosclerosis. But if a patient has CKD, then you are not going to see intimal, but you will also see a medial calcification, which is secondary to CKD. It's important because the vessel becomes more stiff as if there is a medial calcification, and that becomes a problem. So the risk of cardiovascular calcification is increased in dialysis patients as the CKD MBD, which is mineral and bone disease, also worsens. In the Framingham heart study also, the coronary artery calcification rates were increased as the GFR declined further. Now, how do you treat these patients? Always check the PTH and the vitamin D levels from stage 2 CKD onwards. And these patients can be very easily treated with vitamin D, either given weekly or you can give calcitriol if it is required. But remember that always look for vascular calcification in all your follow-up of these patients. And nowadays, we are not recommending calcium-based phosphate binders for these patients. We are recommending non-calcium-based phosphate binders because it will add up to the calcification of blood vessels and add up to the mortality and morbidity. Always you must look for hyperparathyroidism and treat that properly because that is also going to contribute to the vascular calcification. Uremic toxins, again, they increase with the decline in renal function and they also have some detrimental effect to the cardiovascular system. Now, uremia contributes to aging and there are a lot of mechanisms related to uremic toxins. Remember that you can tell your patient what are the problems related to chronic uremia. Chronic uremia contributes to aging and you are going to age much faster if you have chronic uremia. So a patient keeps on asking you, I am asymptomatic, my creatinine is 4 or 5, why do I need to look at it? Why do I need to treat it? But this is the evidence for that. Uremia leads to premature aging and also leads to premature vascular aging and also contributes to mortality and morbidity. So a lot of evidences are there how uremia promotes aging and those who are interested can look up the literature. Also, uremic toxins contribute to multi-organ damage. So not only uremia comes from the AKI CKD, but also kidney heart, kidney liver, and the kidney lung also. Remember that there are some other toxins like cresols, indoxyl sulfate, etc., which are not clinically relevant, but I'm just mentioning it. Endothelial dysfunction is also important because there are pro-inflammatory cytokines. There are some trials going on whether we can reduce the inflammation and probably also reduce the oxidative stress. Some important consideration regarding the gut-kidney cardiac axis. Remember that there is something called as circulating endotoxemia, which is a novel factor in systemic inflammation and cardiovascular disease in patients with chronic kidney disease. So just to remember that the gut microbiome is now coming in a big way as far as all pathophysiologic mechanisms are concerned. And in the future, probably you will see alterations in gut microbiome to reduce chronic inflammation, also contributing to reduce CVD mortality. Metabolic acidosis is very important in patients with CKD. It also contributes to CVD. So I always urge all physicians, if the patient is asymptomatic, still you should look at the bicarbonate level and try to get the right bicarbonate level to the tune of 20 to 22 milliequivalents because you are going to prevent a lot of mortality and morbidity because acidosis is eminently correctable. Similarly, anemia also contributes to the cardiovascular mortality and morbidity, and anemia starts early in CKD and worsens the disease progression. So always remember that anemia also contributes to congestive heart failure. So please treat anemia properly. Always I implore that do the iron studies in all these patients. If you have a ferritin level which is low, if you have a transferrin saturation which is high, again you must think that you must give these patients intravenous iron and treat to the optimal hemoglobin of 11.5 to 12.5, and then try and correct it so that you reduce the cardiovascular disease. And the last point in this particular talk is important. Proteinuria is also associated with adverse CV outcomes. There are many studies to show that. In fact, if you look at the endpoints as far as CV death is concerned, the microalbuminuria has got the maximum hazard ratio to the tune of 1.5. So proteinuria is an important CV risk factor as far as pathophysiologic mechanisms are concerned, whether you are diabetic, whether you are hypertensive, whether you have a normal GFR. So if you have albuminuria, remember that reducing proteinuria independent of blood pressure reduces the CVD risk. So even if your blood pressure is normal, if your patient has proteinuria, do not ignore that. You should try and reduce the proteinuria by whatever methods you have. It is shown in multiple trials that proteinuria is a problem. And again, this particular graph shows you all-cause mortality and CVD mortality is also related to ACR study. These are the last two slides. Early recognition of CKD and collaboration between cardiology and nephrology is very, very important because close relationship exists between eGFR and the cardiac issues, and CKD and CVD, if they are there. If you have CKD, you screen for CVD. If you have CVD, you screen for CKD. Patients with CVD have increases for CKD. Aggressively, you must manage all risk factors related to both CVD and CKD. So to conclude, CKD is considered as a high risk factor for development of CVD. It starts early with a decline in eGFR. Proteinuria is an additional factor for carrying the risk of CVD. Patients with advanced CKD have reverse epidemiology, and in uremia, you must remember all the non-traditional risk factors which play a major role. I thank you for your attention, and again, I thank you for your invitation.
Thank you, Dr. Chafekar, for that elaborate overview of CKD as a risk factor in cardiovascular disease. You covered many of the points. I think there would be a lot of questions on that. But one thing is that my question is that in all this cardiovascular disease, besides giving ACE or ARBs to decrease the progression of the disease, anything else would you like to say? I mean, what could be the other additional factor, which is additional drug, which could help in reducing this eGFR decline?
So what you're asking is which are the drugs which are used nowadays to reduce progression of renal failure? So conservative treatment.
Would you say that in a that SGLT2 can be used for primary prevention?
Yes, so with the publication of DAPA CKD trial recently, just about 2 weeks ago, which all of you know, a lot of evidence is now there that even in non-diabetic CKD or even the routine CKD, SGLT2 inhibitors have shown a lot of positive results as far as progression of chronic kidney disease is concerned, as far as endpoints related to renal death, progression of proteinuria, as well as fall in eGFR. So in the future, what I foresee is that besides ARBs, most of the CKD prescriptions will be having an SGLT2. But remember that there is a caveat here. We must use ARBs very, very judiciously when you are using ARBs for prevention of CKD progression, for the simple reason that there are some other problems like sudden fall in kidney function and hyperkalemia, which you should look at whenever the patient is on an ARB. So there are guidelines of how to use ARBs in people who have CKD. Similarly, as the days progress, we will have guidelines regarding the use of SGLT2 inhibitors, the dosages, and how do you monitor these patients when the patient is on a combination of SGLT2 and an ARB. And besides that, we are also having some evidence that correction of uric acid with drugs like febuxostat also contributes to preventing the progression of CKD. And there are some studies about statins. So statins, febuxostat, SGLT2, and ARBs. That would be a combination of drugs which will prevent progression of CKD.
Okay, as far as statin is considered, what would you choose, atorvastatin or rosuvastatin, and in what dose? You showed a slide, of course that was a bit complicated, but if you can summarize in 2 lines as to the drug of choice and the dosage in what stage of CKD.
So most of the time we are using atorvastatin because there is some relation of rosuvastatin about proteinuria, some concern about rise in proteinuria related to rosuvastatin. Of course, there are only in 2 or 3 studies. So everybody does not agree with that finding that rosuvastatin always contributes to proteinuria. But atorvastatin is an age-old drug. The maximum dose which is used by us is 20 milligrams. But I have already mentioned that if you have an elderly individual, you can use always a statin with ezetimibe so that the dose is less. You can use 10 milligrams of atorvastatin along with ezetimibe so that the dose is minimum. So atorva 10, rosuva 5, that is the recommendation in late stages of CKD.
VT, can I ask a question?
Yeah, Ajit, yeah, go ahead. I wanted you. Sorry, I interrupted you.
Yeah, a couple of things. We have started routinely, having EGFR in each and every patient of heart failure now, before he comes to the OPD. Now, my question to Dr. Chafekar is, what should be the correct method of calculating EGFR? It should be based on the lab findings, or it can be based on your formula of, creatinine height weight formula. What should be the right way?
Most of the laboratories are also using the same formula, but I will tell you what is the validated form. There are 2 formulae which are validated. You can look up on the Google also. One is called as MDRD GFR calculator. This is based on the MDRD study. But the more validated one is called as CKD EPI formula, CKD EPI formula. Again, it's available on the net. So it's a very simple thing. You just have to go on Google search, type CKD EPI, and then you will get some parameters and you will get your GFR. Most of the laboratories are also using the same formula because the parameters required are basically creatinine, body weight, and the surface area.
So that is enough.
That's enough, yeah.
Another point which I would like to make is, whenever when you look at the paradigm trial and the SGLT2 inhibitors trial, both these drugs have shown that the rate of decline of renal function in heart failure is reduced significantly by both these drugs. Not you mentioned about ARBs, but my question was, why should only be? Why did you say only ARBs? Why not a combination of sacubitril and valsartan in these patients? That is one. And number 2, when you look at the decline in renal function in these patients in SGLT2 inhibitors, initially the renal function goes steeply down as compared to placebo, but later on it picks up and then it beats the placebo over a period of long time. So this should be remembered, that even if initially there is a little jump in creatinine and drop in EGFR, one should not get worried and keep on giving these drugs. Do you have any comments to make?
So I'll take the second thing first about SGLT2 and the drop in GFR. Yes, in fact, if there's a drop in GFR, it means that the SGLT2 is working, just as the ARBs also have a drop in GFR. But the recommendation as far as ARBs are very clear right now. If the drop in GFR is less than 25%, then you are allowed to continue the same dose of ARB and watch the patient very carefully. Of course, the patient should not be on NSAIDs and the patient should not be dehydrated. So these are the 2 prerequisites before you interpret that. If the drop in GFR is more than 25 to 30% when the patient is on an ARB, you must reduce the dose of ARB by 50%, and then you are allowed to continue and monitor eGFR weekly. That's the recommendation. If the drop in GFR is more than 50%, then you have to stop the ARB. So these are the recommendations as far as ARB is concerned. There are no such recommendations right now, but I already mentioned that as time goes by, we will be having some recommendations with the use of SGLT2. It is true that there is a fall in GFR to the tune of 10% in people who are started on SGLT2, but it stabilizes over a period of time, and the renal protection advantage is much better with SGLT2. Can I answer the second question? The first question about the ARNI.
Yes.
Yeah. So, as far as ARBs are concerned, everybody is using it for a long period of time. As far as ARNI is concerned, we as nephrologists had two concerns. One was about hypotension, and second was about the hyperkalemia. So, initially, when we started using ARNI in our practice with mild CKD, even if it was advised by the cardiologist, these concerns were true and genuine. But now, over a period of time, even personally, we have gained confidence to the use of ARNI. And few of my patients who are even on dialysis, they are on ARNI. So it just shows that as you use the drug more often, you get more and more confident. So we are using ARNI in some of our patients when it is.
Yeah. So based on whatever you have said, is it fair enough to say that you should be very selective not to start ARB or RAS inhibitor plus SGLT2 simultaneously together to a patient? Otherwise, the drop in EGFR might be much more than when starting a single drug. So would it be right to say that you should be cautious not to start both of them together?
Yes, so if the patient is already on an ARB for a very long period of time with a stable renal function, you may be justified in adding an SGLT2. But if the patient is not on any of these drugs, then it's ideal that you start one and then add the other with a careful monitoring of renal function. Yeah. And there are all the other caveats which are important, like dehydration and other things.
Yeah. So definitely very good points, especially dehydration, because dehydration both for ARB or ARNI and for SGLT2 inhibitor is not a good thing to be in that situation. Dr. Avhad, now are there any questions there?
Yes, sir. Sir, there are many questions. I'll just take two or three. One question is, how can you suggest one drug to reduce the albuminuria?
So the most important drug is, of course, RAS blockers. You can use an ARB or ACE inhibitor in whatever maximum tolerated dose. But remember that ARBs are more commonly used because of the side effects related to the ACE inhibitors. But you can use either.
Otherwise, ACE inhibitors also you would advise in the same way, right?
Yes,
or
of course.
Nephrologists have a choice more for ARB than ACE inhibitor. Is it something like that?
No, it is not like that. The evidence is for both. So RAS blockers in general are used to reduce proteinuria. But the only caveat is the side effect profile. If you are comfortable with ACE inhibitors, they can be continued.
Sir, please opine on the role of PCSK9 inhibitor in dyslipidemia in CKD.
So there are no trials as far as this particular molecule is concerned in patients with CKD. And right now, in fact, there is no recommendation at all. So if you have a patient, then it will be used very, very judiciously, because it has to be used for a long period of time.
Okay. Sir, one more question from our President-elect, Dr. Jitesh Mehta. In this corona pandemic, is there any protocol in the treatment of CKD and CAD?
Yes. So as far as the pandemic situation is concerned, remember that the corona infected patients, they are more prone to multi-organ failure. So therefore, we must take all measures to prevent multi-organ failure by doing the right things. So from the renal perspective, you have to avoid nephrotoxic drugs, number one. You have to avoid all causes which cause pre-renal azotemia, number two. Judicious use of medications and the hemodynamic stability is also very, very important, because a fall in blood pressure and rise in heart rate, etc., are detrimental. And the other factor is, of course, infections. So super-added infections in the pandemic are to be treated judiciously. So these are the four things which I can say are important as from the pandemic perspective. Now, as far as CAD is concerned, the management would essentially remain the same as advised by the cardiologist, with all these caveats in mind.
Thank you, sir. Sir, we can move ahead.
Any other further questions?
Not from my side, sir.
Yeah, okay. Thanks, Dr. Chafekar, for those wonderful answers and along with your lecture. It was really interesting for us to hear from you all your views about CKD and cardiovascular disease. So now we go on to our last talk of the day, and that would be by none other than Dr. Shirish Hiremath, who was our president of our national CSI a year or two back, and he is the director of Cath Lab at Ruby Hall Clinic, Pune, and he has done his cardiology from Sion Hospital. Lot of experience both in interventional as well as in clinical cardiology. So, as I told you earlier, that this year I thought it would be appropriate to have speakers from all over Maharashtra, and therefore I requested Dr. Shirish Hiremath to please give a talk and address to IMA Mumbai branch, although he's a very busy practitioner and very busy in webinars also. So, but thanks to Shirish for sparing time for us. Over to you, Shirish. Thank you.
Sir, left hand side there is a plus sign is there. Kindly click on that. Sir, your voice is not audible.
From laptop. Sir, just remove the earphone. Maybe sir, yeah, from the laptop also. I'm just restart your video. Please accept, sir, video request. No, sir, you are not audible. No, sir, you are not audible. Can you just refresh, sir, once the link?
I want to share my screen.
Yeah, we can hear you now.
Yeah,
And
now
your
you can hear
screen-
me.
Yeah, and your screen is loading.
Sir, you need to select, yeah, shared, sir.
So good afternoon, everybody. This is the last talk of the morning. Indeed, thankful to IMA Mumbai for this invitation. And my friend Viti, of course, is there, and it's indeed a privilege meeting Dr. Attar and Dr. Pankaj Bandarkar this morning. Our connect with Mumbai is through CAD, which we host every year in Mumbai. This was the humble beginning when CAD was in Nagpur and Pune. And then for last many years, along with Dr. Madikar, we have some great faculty coming to Mumbai for this meeting. So if you have not attended this meeting, please make it a point to meet come to CAD this year. So when we talk of a cardiac problem, they happen suddenly. So out of these 100 gentlemen on the screen, this blue one gets picked up and he suffers a heart attack. Now, how to pick up those? Those who have increasingly high BSL values, those who have increasingly high HSCRP, they are probably at the highest risk. So this was a big study over a lack of health professionals and nurses were followed up for almost 14 and 10 years, and this kind of conclusion was drawn. So we must respect that once you have risk factors, we need to sort of take care of them. And today we are basically focusing on how to control risk factors. So when we talk of lipids and statin, we had, this is a gentleman at 29, he had an inferior wall infarct. So this was an acute event which was fixed as an emergency. However, he had two more episodes, one at 42, about 13 years later, and one at 49, about another 7 years later. However, these were picked up before he got an infarct. This is important because once there is infarct, you lose heart muscle, which is difficult to recover. So if you pick up by a test the problem coming up and fix it, as you can see here, your ventricle is preserved. This gentleman is now 10 years after his 49 age angioplasty, and he's doing extremely well, functionally very normal. So this is possible if you achieve a good LDL value. And you can see here, instead of using 10 milligram, if you use 80 milligram, you get a bigger dip, and your major cardiovascular events are strongly prevented, a very significant drop. This is from the TNT study. Improve It actually used ezetimibe over statin. So if your patient is not at target, now this target we'll discuss in next few slides, but if you're not at target with statin, add ezetimibe as your first next option, and it will help you a great deal. Like this is seen in Improve It study, there is a substantial drop. Now this was a diabetic subset who was on standard therapy, which is sort of low dose statin therapy. When we say low dose, we are actually talking of about 10 milligram of rosuvastatin or atorvastatin. However, when you switch to high intensity statin, high dose statin, there is a clear bigger drop, almost 20% drop in LDL. And obviously this is going to prevent episode. Is there any price to pay? This is a Korean study, Taiwan study, which clearly shows that high intensity statin and non-high intensity statin, let's say 10 to 20 milligram here, and say 40 to 80 milligram here, and there is no difference in the side effect profile. So using high intensity statin is effective and it's quite safe. To this, now we have a PCSK9 inhibitor available in the market. This is one injection every 2 weeks at the moment. We may get one injection once every month soon, but the effect is extremely strong. Like you can get 90 coming down to 30 within few days and definitely inside 2 weeks. And this can be maintained at this grossly reduced level if you continue with this injection evolocumab. Just to give you an example, this was somebody who had multiple vascular events, coronary, TIA, leg claudications, and we were unable to get his LDL down. It was always staying at about 83, 84, despite 40 milligrams of rosuvastatin and ezetimibe. Once we added evolocumab injection, it immediately dropped to around 50 and then subsequently 46. So this is a big benefit coming out of these molecules. Do you use it for everybody? Absolutely no. You have to have defined ideas. People who have multiple prior myocardial infarction, multivessel disease, one event, cardiovascular with diabetes or CKD, and a recent ACS. Now this is important because if you start early enough after an acute infarction, the benefit is much, much more. So under these settings, one would certainly like to use the evolocumab, which is already available. This is another injection, inclisiran, not available today, but this is to be taken once in every 6 months, and the NHS in England is actually doing this. So this is actually gene silencing medicines to be taken once in 6 months. So So the guidelines are clearly changing all the time, and this is actually 2016 guidelines, the ESC, which said that for very high risk, it should be less than 70, the LDL, while same ESC 3 years later, now in 2019, is talking of less than 55 as a guideline. So 4S started with 180, bringing down to 120. This was the initial early 90s study, which really started the ball rolling. So very important study, but subsequently, lower is better became lowest is best. So this is what evolocumab is trying to tell us, that if you go even further down, no harm, and you are going to get a clear benefit. The Lipid Association of India, way back in 2016, 4 years earlier, also highlighted the importance of LDL lowering, because Indians get heart problems almost 10 years earlier compared to Westerners. So the target for Indians is less than 50. So for very high risk patients. So very high risk includes those who already have a coronary event, diabetes with evidence of end organ change, or more than 2 risk factors, and familial homozygous hypercholesteremia. So these are the high risk individuals. And the ESC guidelines 2016 to 2019 again changed the targets. So this umbrella was widened and more patients could come under the effect of statins. And this actually prevented more acute events. In 2016, guideline indicated therapy prevented 11, while 2019 it could be 25%. And again, no price to pay because side effects are very few. So the evolocumab or PCSK9 inhibitor, those who have peripheral artery disease, now this is a very important thing, those who have peripheral artery disease, most of them will have coronary disease, and many would also have a carotid disease. So this becomes a class 1A indication for giving big dose statin, ezetimibe, and a combination with PCSK9 inhibitors. So what it can do, the high intensity statin, is those who are likely to get it at 20 years, so very high risk, would sort of stay away from heart problems for a longer time, and maybe instead of 20, they would get it at 50 years. Those who are expected to get it at 50 will get it at 70 or 80 years. So the onset of disease or atherosclerotic presentation is clearly delayed by a combination of statin, ezetimibe, and if required, PCSK9 inhibitors. So this is again trying to tell you the same thing, that those who have very high risk, they have to be sort of nurtured and carried very gradually for a long length of time with effective therapy. So the lifetime CVD risk, you can clearly see low is less than 15%, while high could be as high as 45% or more. So always make a difference. When patient is in front of you, see what kind of risk factor he had, 0 to 1, whether he has already an established disease like ASCVD. And there are gradations which will tell you whether it's a high risk or very high risk. This is familial heterozygous hypercholesteremia. E stands for heterozygous. So these people generally present like these two are brothers, and they have another brother who actually came much earlier, 2 years earlier. So they all got it around 35 to 40 years of age, a coronary event fixed with angioplasty. But this was another one. At age 37, he had the first event, and we put a left main stent at his insistence, because that time for left main bypass was the rule. This was actually a bare metal stent. However, and as expected, he had a stent restenosis. At this stage, we told him that you need to go for surgery. Again, he insisted on a angioplasty, and we offered him a drug stent, which was just released at that time. So this is somebody who has moved from age 37 and he's giving a public talk to the press 10 years later, how he moved from age 37 to age 48. And he's a professor in one of the colleges in Bombay, now nearing 58, 59 years of age. This is possible. You do a good job and you follow it with good effective therapy. Now, this is FHO, which means it is a homozygous familial hypercholesterolemia. This girl actually had first event when she was 11-years old. One of the pediatric residents was smart enough, so he made her walk a little bit because she was complaining of chest pain, inability to walk. And she was actually living in the hospital premises. So he made her walk on a plain level, did an ECG, which showed huge ST depression. And her angio showed a critical disease in the left main and also in LAD. Her elder sister, 5 years older to her, she had, again, severe hypercholesteremia. They both had total cholesterol of more than 800, LDL of more than 500. And this 5 years older to Pallavi, she had supravalvular calcific stenosis. And in addition, the whole aorta was extremely calcified. She had to undergo surgery for removal of this calcium cast, which was obstructing. In addition, she needed a couple of grafts. So this was about platelets and liquid therapy and advancing liquid therapy. Let's move on to the antiplatelets, what people understand as blood thinners. And yes, we used to have this aspirin given for chronic prevention. However, a lot of data has now come, especially from Salim Yusuf, which tells us that if you have no risk factors and if you are young, aspirin probably has no role. In fact, going further, when we have these more effective antiplatelets available to us, the role of aspirin is getting more and more challenged. So today, if somebody is not given aspirin, I will not be surprised. When we talk of antiplatelets, we also talk of clopidogrel, along with prasugrel and ticagrelor. All of you know that these are stronger antiplatelets, more effective than clopidogrel. And the most important thing is they have known drug resistance. Clopidogrel, a sizable percentage, almost 20%, have a resistance. So you do a good angioplasty, you put them on clopidogrel, and if there is a resistance, they will come back to you in a few days' time with stent thrombosis. This is not true with these two medicines. So there are differences between the two, and I'm sure all of you understand that stronger, more potent molecule is likely to bleed more. Why don't you give it to everyone? This is the reason that the bleeding possibility is more, and clopidogrel is a good balance between ischemia safety as well as bleeding risk on the other side. Now, this was a study, the Pegasus, which indicated that the newer molecules are clearly more effective than aspirin alone. And this benefit does not stop at 12 months. Traditionally, we all give it for 12 months. And beyond that 12 months, we are very soft on antiplatelets. But these studies indicated that if you continue beyond 12 months, say up to 3 years when the study was stopped, the benefit continues, and the people who are getting ticagrelor will get that kind of benefit. Ticagrelor is available in 90 and 60 milligram, so you could choose either of them after 1 year. Is it applicable to everybody? Obviously, no. So it is indicated, extended antiplatelet therapy is indicated for those who are 65 and above, those who have multiple myocardial infarctions in the past, those who are diabetics, chronic renal dysfunction, and those who have multivessel disease. So under these settings, if your patient falls into these, think of extending the antiplatelet therapy for a longer time. Whether it's 3 years or 5 years, you'll have to individualize. But do not try to do this if patient already has some kind of bleeding diathesis. Patient had intracranial bleed. Patient is also on anticoagulations for atrial fibrillation. And patient has severe hepatic impairment. The good thing is those who have not bled in first 1 year, they will not bleed beyond 1 year. So it's kind of indirect conclusion that those who are quite safe in the first year and not bled, you can think of continuing them if they have all these criteria or some of these criteria. So yes, we want to give it, but be cautious when you want to give it. Now, this is a study which actually dropped aspirin completely. Angioplasty was done, and at the end of 3 months in Twilight study, aspirin was not given, only ticagrelor was given, and the other arm continued with aspirin. This was a comparison, and it showed that the ischemia benefit was not different in either group. So that means dropping aspirin, giving ticagrelor monotherapy is as effective as a combination. What aspirin does, in fact, is it increases the bleeding risk. So this was plain ticagrelor, and this is a combination of ticagrelor with aspirin. So why buy a risk when both the therapies are going to be effective? At the moment, we are not following this in clinical practice. But yes, if your patient falls into high bleeding risk category, I think you can take help of this study and stop aspirin. Also, when you compare these 3 molecules, ticagrelor, as you know, is given in BD dosages. This is because the duration of action is short. And that's why, for some reason, like patient needs a surgery or tooth extraction, ticagrelor is a softer option because a short 3-day stoppage is good enough. For clopidogrel, it is 5 days, and for prasugrel, it is 7 days. So ticagrelor may have some advantages. Now, this balance of bleeding on one side and ischemic risk on the other side is also important when you decide who undergoes angioplasty and who undergoes bypass surgery. Today, we have very advanced stents, and this is one such study where these 2 stents are compared. Biofreedom was approved by the European Society, and that's why this Resolute Onyx was compared with Biofreedom. And you can see stoppage beyond 1 month. 1 month jabbed did not make a difference, and both were effective. So one is polymer with polymer, and this is without polymer. And even if you stop adapt, it did not make a difference. What about anticoagulants as a preventive? This is a new concept, and the COMPASS study was very important in showing that addition of rivaroxaban in a different dose, aspirin and rivaroxaban aspirin, for these criteria. These were the enrichment criteria: patients older than 65, smokers, diabetics, renal dysfunction, heart failure, peripheral artery disease, very important, carotid, and prior stroke. If your patient has all these, we saw these criteria earlier also when we talked about Pegasus. So this is a NOAC. As you know, the conventional dose of rivaroxaban used for atrial fibrillation, used for stroke prevention is 20 milligram, and a smaller dose is 15 milligrams. However, in this study, they used what is called as a vascular dose of rivaroxaban, and this is 2.5 milligrams twice a day along with aspirin. And it clearly showed that there is a very significant reduction in all these. MACE events were reduced. Most striking is the amputations. So if your diabetic patient has peripheral arterial disease, this becomes a very, very strong indication. This is called as the DPI, or dual pathway inhibition. That means you are attacking the antiplatelets, and you're also attacking the coagulation cascade, and together you are giving a benefit to this population. So many diabetics have peripheral arterial disease. Many of you do ABI in your office practice. Then you do a Doppler if there is some kind of suspicion. And now you think of putting them on this vascular dose of rivaroxaban. The next point, and very important, is an early initiation of therapy. Now, this is important because all these statin therapies, we know that they can produce a significant drop. But if you wait too long, like somebody has come to you with an abnormal lipid report at the age of 38, 40, and you say, okay, we'll wait, and the patient doesn't turn up, then he's probably carrying that high LDL level for a longer time before he comes to you, and maybe he would come with a impact like an event. So the magnitude of drop is very important. So today the targets for LDL are moving downwards, and a target of less than 40, as I showed you, is recommended by the Lipid Association of India for people who have a CVD. So magnitude, that means the drop, level of drop, say 50 or at least 50% of the current value is very important, but also the duration of exposure is very important. So bring it down and keep it down for a long, long time. And by doing this early initiation, you can improve the lifespan of the patient. So instead of presenting very early, say something like 30 years, they will move on to age 60 without any events. Now, this is also highlighted by UKPDS, which indicated aggressive control at an early stage. So this was UKPDS duration, and then they were followed up for next 10 years. So those who received a very aggressive early therapy, tight sugar control, they continued to get that kind of benefit 10 years after this study was concluded. And same is indicated by the Ascot legacy study, where for blood pressure, a combination of perindopril indapamide was given, and blood pressure was aggressively controlled. So those who had very strong control in the early period, they continued to show benefit during 16 years follow-up. This is actually beyond the study, and all of us know that this is called as a legacy effect or a metabolic memory. So same holds true for statin, that start early. So when you talk of prevention, a patient who has come to you at an early stage with an abnormal report, don't say, oh, come back, we'll see after some time. Patient will feel happy that you're not prescribing a medication. However, we are doing a harm to him by allowing him to carry the risk factor in those important initial years around 35, 40, 45, and allowing him to come back with an atherosclerotic event anywhere. So this gentleman who moved from 37 to 48 and now 58 and 59, his LDL, we keep it down to less than 50 for last 10 to 15 years. So we had to take a lot of effort, a lot of convincing for him to do this. So we talked about different kind of medications going through statins and others. For lipid lowering, we talked about antiplatelets. We talked of combination of aspirin with anticoagulants. And now we talk of early picking up coronary disease. And this is where the importance of CT angio is extremely important. If CT angio shows that there is no disease, the arteries are very good. The accuracy of CT angio is almost 100%, just like a conventional catheter angiogram. In fact, CT may have a little advantage because it also looks at the vessel wall. So it's a conventional catheter angiogram is a luminogram, while CT angiogram, of course, shows the lumen, but it also allows you to look at the vessel wall, whether it's calcified, whether it has plaques, and so on. So this is a very important study, the Scott Hart study from Scotland, had indicated this was a very mass study, and it's a big study followed over a long length of time, more than 3 years. And those who had CTA guided sort of evaluation, whether they undergo revascularization or they go on statin, etc., all based on CT angio. So just as you say that somebody has a myocardial infarction, his LDL must come down to less than 40, evidence of atherosclerosis on CT angio should be taken as a case for secondary prophylaxis. So those who are positive for CT angio, no events, even them you must give a LDL target of less than 70. And this is what you see on CT angio, which tells you that the plaque seen on the CT angio is vulnerable. So these are some of the criteria: positive remodeling, where the vessel actually becomes fatter than the remaining side, spotty calcification, low attenuation plaques, and napkin rings. So these are the 4 criteria which are likely to tell us that the individual who may have a CT angio which is close to normal, yet these criteria indicate that the plaque is likely to rupture and patient is likely to have an event. So these are actually various ways in which you can score the CT angio to decide how vulnerable is the plaque and take a call. Now the FFR is actually measured in the cath lab, but this is very important, and I thought we should know that the plaque vulnerability, which we saw in this previous slide, it can also be assessed in the cath lab by doing FFR. So if you're doing an angio, do FFR for borderline lesions. If the FFR is less than 70, your plaque is vulnerable, likely to give somebody infarct. So this should be addressed. While if your FFR is normal, close to 1, your plaque vulnerable is a very small possibility, and you can conserve these people. So both an invasive physiology evaluation with FFR and a non-invasive CT angio anatomic are sort of matching each other and giving you a good sort of future direction. So CT tells you about the coronaries, the cardiac MR tells you about the functionality, and if you go together, you can guide the patient as to whether he needs to go for invasive evaluation, invasive therapy like a angioplasty. So we are awaiting for the many of these diagnostic CT installation to start doing non-invasive FFR. It's just around the corner, and we would get it. So non-invasively, you can find out if somebody has a lesion. Non-invasively, you can find out if the lesion is likely to rupture and give you an infarct, and also tell you how much is the gradient across that lesion, and if it is a significant gradient, the patient needs to go in for angioplasty. So calcium score becomes very important. Those who have 0 calcium score, they are close to normal. So calcium is actually a marker of atherosclerosis, and this is where in this particular guideline, where calcium is there, but score is less than 99, especially after age of 55, this could be an indication to start statin. Now here, we are not taking LDL into consideration, just the presence of calcium is probably taken as an indication for statin. If your calcium score is more than 100, then of course you need to initiate statin therapy, irrespective of lipid levels. Now, when somebody talks about angina, we say, oh, he has some disease. When he walks, he gets some fullness in chest, but otherwise he's fine. He's going for work. He's going for walk in the evenings, playing tennis in the morning, and so on. However, one must understand from this Swedish study that once you get a myocardial event, the possibility of another event is 1 in 5. That means 20% will get an event in first year after a first stomach or infarction. And another 1 in 5 will get it in subsequent 3 years' time. So at the end of 4 years, only about 60% will remain stable, while another 40% will have repeated events. And these events come not from the culprit vessel, which gave the first episode, but they come from the non-culprit lesions. So if an angiogram has shown 20%, 30% narrowing, this is a non-culprit today. But this could be a future culprit, and we need to worry about this non-culprit lesion, which is non-obstructive, but yet can give a plaque erosion or a plaque rupture and an acute event. So stability is never a true stability, and a repeat event is certainly a possibility. Like in this case, 1997, age 50, diabetes for a long duration. He had a small event from this lesion, and patient, since the lesion was very distal, was classed for medical therapy. Patient subsequently, 1 year later, had progressive disease, and this in those days was used to long lesions were done with angioplasty with only balloon. So balloon was done, which is still functioning okay about 5 years later. So this is telling you a progression. 97, 98, and 2003 stress thallium was positive, and he had multiple blockages and underwent bypass surgery. So he got 5 grafts. So bypass surgery has also advanced. This is all arterial grafts which remain patent for a long time. So this is a lima, typically done as a Y with rima. And there are 1, 2, 3, 4, and 5 distal grafts. However, nothing is permanent. Angioplasty is never permanent. Bypass surgery is also never permanent. And this patient actually developed block in this portion and block in this portion. As you can see here, after 8 years' time, there is a block in this part and this part. So what do? I mean, this portion is not getting blood, right is not getting blood because these portions are obstructed. So here comes help from the angioplasty. The right artery, which was occluded at the time of bypass surgery, this is a CTO, chronic occlusion, opened up. We put a drug balloon here on this side, drug stent here. And on the left side, we put another stent from left main to OM. So this was improving supply to the OM branch, and through this patent arterial graft supplying to the distal OM. So this is how the revascularization is re-established. Patient had 1 angioplasty in 97, surgery 2003, and another angioplasty in 2011. So a course of about 25, 30 years may need this kind of support intermittently. So coming to close to conclusion, we had this study in 2006 where chronic stable angina was considered that it can be managed equally effectively with angioplasty as well as medical treatment. So there was a lot of criticism to this study, and in came a study in 2019, the ischemia study, which actually took away all the flaws which were there in the previous study, the courage study. And even now, there are sort of cases where both conventional conservative therapy can be as effective as intervention therapy. So whether you revascularize or whether you treat them, this is not true for all the cases. You must see the criteria. But overall, those who have low risks, as you can see, there are fewer age. That means they do not, few of them need intervention. While those who are class 3 or class 4 angina. So angina is a very strong guide to tell you that this patient needs revascularization. So all these A's in green for high risk as well as those who are having class 3 or class 4 angina are the ones where revascularization is considered very appropriate even in stable angina. Certain cardiac deaths, you already heard, this is a kind of fibrillation the patient can have, and this is a fibrillating heart. So on ECG, it looks like this. This is actually lead 1 being recorded many years back. That time we had those single lead ECGs. So I'm a really old practitioner, this tells you. And patient, as lead 1 was being taken, fibrillated, brought back to sinus, had still some kind of arrhythmia, and then stabilized. So this patient underwent an angioplasty. It's about 35 years, and he's moved to US and is doing extremely well. So these kind of devices, the ICDs, can again prevent sudden cardiac death for you. And let's look at some future thought. This was Andreas Kunzik, who did the world's first angioplasty. This is the lesion for which angioplasty was done. And Bernie Wire was working with Andreas Kunzik on this case. We invite Bernie to India very often. And this is, I'm doing a live case with Bernie Meyer on this occasion. And this is the gentleman who actually decided to offer himself as a guinea pig for the angioplasty. So world's first procedure, which I showed you here, is done on this gentleman. And we invited to celebrate 3 decades of angioplasty for one of our CAD conferences. You can see the logo of CAD here. And he's having a chat with me. I asked him, what do you take? And he says that I walk a lot. And he lives, he's in German part of the Alps, walks a lot. You know, I can see a little bit of plumpness, but he says he takes 1 tablet of aspirin and one tablet of statin. And he's doing extremely good for last 30 to 40 years. So the angioplasty techniques have also advanced. This is a very frail elderly lady, 39 kilos, creatinine 1.8, clearly high, came with a semi-urgent inferior MI with an occluded right coronary artery. So we put 2 stents here, and at the same time we put another 3 stents on the deceased left system. So total 5 stents when she was wheeled out of the cath lab. And this is an angiogram at the end of 6 months. So angioplasty has come to stay. Good quality stents, very effective angioplasty, and can give excellent benefit to the patient in the long term. We now also have different tests like FFR. Like this lesion does not appear critical to me, but patient had a clinical angina and a stress test was positive. So we do FFR, and as I told you, if FFR is less than 0.75, this becomes an indication for angioplasty. So patient underwent an angioplasty. And this is for calcified lesions. These are very hard, difficult to open with balloon. And you use a drill called rotablator, and you can see this drill. This has got glass particles on the tip, and this is actually making its way through the lesion, and thus angioplasty can be effectively done. A recent advance, you can see this is a lithotripsy balloon called IVL, and with every pulse, it sort of sends impulses which actually hit the calcium. So difficult lesions, hard lesions, calcified lesions, they are first done with this and then with balloon and stent. The worry when you do not use methodology like this is some of the lesions will not expand, allow the stent to expand, and can actually lead to perforation. However, I must say, I have seen angioplasty evolve a great deal. This was a gentleman who was rejected by the surgeons for high creatinine. In addition, he had lots of peripheral issue. He had a block in the origin of the right subclavian artery, the left subclavian artery. Again, was critically narrowed, as you can see here. The left renal artery was also narrowed, along with near total occlusion of the right. In fact, anomalous origin and LAD left main disease. All were fixed. One, the right, then the LAD left main, then the right hand, the nominate artery, the subclavian artery, and the right renal. It was a 4.5 hour procedure. I felt like a surgeon at the end of this procedure because we were so tired and exhausted. We were also able to keep the contrast load down, no renal issue post-procedure, and patient could go home on the fourth morning with this aggressive therapy. So we are not trying to say that we are competing with the surgeons or they are competing with you. You need to sort of decide what is good for a patient, whether surgery is good or angioplasty is good, and make a choice which is going to be very helpful. This is actually a tower, which is a percutaneous aortic valve, and you do. This is a gentleman, 88-year-old. When I told him you have a valve which is critically narrowed and you will not survive beyond about 1 or 2 years, he asked me, "Is there anything else I can do apart from valve replacement surgery?" And this is the time this tower was just introduced. So this valve is, and this is a similar case again. Somebody who is about 85, 90 in that group, walking next morning and home within 1 week's time, doing everything at home. So I'm deeply obliged to Alan Cribier. We spent some time with him trying to learn angioplasty way back in 1992. And he actually did the world's first percutaneous aortic valve replacement. This is Alan Cribier with his world's first patient. And the surgeon have also accepted, like when they do a surgery, they put this kind of belt which can be stretched with the percutaneous technique, and you can put in a bigger hole. So surgeons, angioplasters are sort of working together, and this is offering safety first to the patient. So as a patient, what you should do is sort of look at what is your risk score. So there is an actual age and there is an arterial age. So based on all these factors, whether you're a smoker, you're diabetic, whether you have hypertension, how low is your HDL, how low is your LDL, you can decide. If your arterial age is more than your actual age, I think you need to worry about. So there are newer therapies. This is actually ARNI, beta blocker, and ivabradine for heart failure. And then you have these SGLT2 inhibitors for diabetic with heart problem. So diabetes treatment is just not around lowering sugars, but we are also looking at cardio safety. In fact, now we are looking at cardio benefits. So a lot of non-diabetics are also getting diabetic drugs. So this is a kind of precaution you must take. Weight must come down. So we spoke about secondary prevention. That means those who have ASCVD, those who have risk factors like diabetes, high cholesterol, blood pressure, they fall into primary prevention. The targets here are clearly lower than an average person, and targets for secondary prevention are clearly lower. So a good thing is, by doing all this, we are able to take the patient safely for a long, long time. So this is for regular patients who want to not get into cardiovascular issues. So you do preventive care, which is primordial prevention, and also to some extent primary prevention. Whenever an acute event happens, the bags will come out like angioplasty or a bypass surgery, which will salvage the situation to some extent. But once you start redriving, that means a few weeks after bypass surgery or angioplasty, we must take care very aggressively, bring your LDL down, take antiplatelets, bring your blood pressure down. So when you want to sort of drive from birth to a natural death, let's say death around 80, 85 is acceptable. You will, for a vascular case, you may need more than a few healths. This is actually infarct, which can lead to a premature death. So you may need a procedure, angioplasty, to come back to the course. You may need a bypass surgery to stay on track, or you may need bypass surgery and an angioplasty to stay on track. By doing all this, you can achieve a good, healthy, long life. And so with this, I conclude. I say hello from my colleagues and friends from Pune. I've been in Pune for a long, long time, though I did my cardiology training in Mumbai. So hello to everybody from Pune. Live healthy, live safe. We have lots of tools which can keep a heart patient healthy. Thank you indeed. And I can't thank you, thank the IMA Mumbai for giving me this, can't thank them enough for giving me this opportunity to talk to you all today. Thank you indeed.
Yeah, thanks. I think. Thanks, Dr. Hiremath, for this wonderful overview of.
We can stop and take questions.
Yeah. So thanks, Dr. Hiremath, for taking us through this journey and a wonderful overview of all the advances that have been made in managing cardiovascular diseases, and especially some of your experiences over this vast number of patients and number of years to manage them and lead them to a natural history of living healthy hearts. So with this now, Dr. Avhad, some questions to be taken?
So there are no questions in the chat box.
Yeah. Wonderful. So let us see now, Dr. Hiremath. First of all, regarding this, what is your take nowadays about giving statins, high dose statins to your patients, especially after a procedure or an ACS event? You stressed upon the fact that not only it should be given high dosage, but physicians generally, after achieving the target, they reduce the dose. What is your take on that? What would you say? How should you follow up this patient?
It is saying poor connection, please wait.
Yeah.
I don't do anything, right? Okay.
Am I audible, Shirish? I think we are not audible to you.
It seems that.
Samir, can you help? Have you lost us?
I'll try to call him. Wait a minute.
So, friends, in the meantime, let me thank all of you for being here with us. More than 500 participants who have joined us today on this event. And thank to all our esteemed speakers for sparing their time and giving us
Can I give the vote of thanks?
Yeah. So, Dr. Anil Avhad.
Yeah, I'll just give a short vote of thanks. I have the proud privilege to extend vote of thanks at the end of this World Heart Day program. Our heartfelt thanks goes to the speakers, particularly Dr. VT Shah, Dr. Niteen Deshpande, Dr. Ajit Bhagwat sir, Dr. Deodatta Chafekar sir, and Dr. Shirish Hiremath sir for sharing their knowledge, experience, and expertise. Special thanks goes to Mankind Pharma for being our knowledge partner for today's program. I thank our MMC observer, Dr. Girish Lad, for supervising today's program. Last but not the least, the credit of the success of today's program goes to the delegates for their enthusiastic and overwhelming participation. I sincerely thank all of you. Over to Dr. Vitisha, sir.
Yeah, so thanks, Dr. Avhad, for this vote of thanks. And again, let me also special thanks to Mr. Samir Jadhav for seeing that the whole program goes event-free with some very minor glitches, but otherwise it went on well. And again, thanking IMA Mumbai branch for this wonderful World Heart Day program we had this year. with 500 participants. I think Dr. Attar should be thanked specially, and lucky to have this best program. Even on the
Thank
13th,
you.
we had a wonderful program of more than 1,500 delegates. So, in a way, this is an advantage to IIM Mumbai branch that we could participate in this program. So, thank you all of you. Stay safe. Have a good lunch now. Unfortunately, we cannot serve you by Swiggy or Zomato.
Thank you, sir.
Yeah, but maybe next time we'll see again. Thank you, everybody. Stay safe and goodbye.
Thank you, sir.
Thank you.
Thank you.
Goodbye.
Goodbye.